что? Ну, запиши. Уважаемые коллеги, прошу.
Dear colleagues, please take your seats. We're starting the conference.
Уважаемые гости.
Dear guests, friends, and colleagues, participants in this anniversary conference, welcome.
Разрешите приветствовать вас всех в нашей столице Узбекистана с многовековой историей в городе Ташкенте. Мы рады всех вас видеть на нашей международной научно-практической конференции «Фундамент отечественной фтизиатрии. Истоки и перспективы инноваций в профилактике, диагностике и лечении» является одним из важнейших событий в календаре медицинских мероприятий текущего года, объединившего 3 исторические даты. Это 100-летие фтизиатрической службы Узбекистана, это 110-летие основателя нашего центра и основоположника науки академика Шакир Алимовича Алимова и 90-летие нашего центра, Республиканского специализированного научно-практического медицинского центра фтизиатрии и пульмонологии. И разрешите первое слово предоставить в качестве приветствия от Министерства здравоохранения профессору Сабирову Улугбеку Юсуфхановичу, заместителю министра Министерства здравоохранения. Прошу вас, Улугбек Юсуфханович.
Ассаламу алейкум, ханымлар ва джанабlar. Доброе утро, дамы и господа. Разрешите вас поприветствовать в столице Узбекистана, в городе Ташкенте, где сегодня проходит международная научно-практическая конференция «Фундамент отечественной фтизиатрии. Истоки и перспективы инноваций в профилактике, диагностике и лечении», посвященный 100-летию фтизиатрической службы Узбекистана и 90-летию научно-практической деятельности Центра фтизиатрии и пульмонологии. На протяжении многих лет в Республике Узбекистан осуществляется ряд комплексных мер, направленных на построение демократического правового государства, обеспечивающего соблюдение прав и свобод человека. Главной целью проводимых в Республике преобразований является гармоническое развитие и благосостояние людей, реализация их прав и интересов в отношении здоровья и благополучия. За короткий период независимого развития Узбекистана достиг колоссальных успехов. В настоящее время в нашей стране сформирована качественно новая, отвечающая высочайшим требованиям целостной и надежной система медицинских учреждений, состоящая из учреждений первичного звена, республиканских и областных центров, специализирующихся на десятки таких отраслей медицины, как хирургия, кардиология, урология, терапия, эндокринология, фтизиатрия и пульмонология. И на данной конференция также посвящена столетию. Обратите внимание, 100 лет этой службе. То есть туберкулез был, туберкулез есть, туберкулез будет. То есть мы должны всегда быть начеку и всегда думать, как его вылечить, потому что антибиотики, которые мы изобретаем, все равно идет резистентность, и поэтому мы всегда должны в первую очередь предотвращать это заболевание. Самое важное, эти широкомасштабные реформы созвучны стратегии здоровья 2030 и направлены на повышение благополучия жизни во имя человека и его интересов. Учитывая приоритет развития здравоохранения на современном этапе, а также высокий уровень распространенности респираторной патологии и медико-социальной бремени от заболеваний органов дыхания, особое внимание в республике уделяется развитию специализированной фтизиатрической и пульмонологической службы. И не зря именно руководством страны, президентом обращается большое внимание на эту службу. И издано 2 постановления, и готовится еще постановление президента, которое именно направлено на профилактику и лечение этих заболеваний. Самое главное – это предотвращение. То есть государством уделяется большое внимание данной области медицины. Политическая приверженность и государственная поддержка, реализуемые в мероприятиях, постановления президента и правительства обеспечила снижение основных эпидемиологических показателей по туберкулезу за последние 10 лет. Заболеваемость снизилась в 1,5-2 раза, смертность в 6 раз. А такие показатели достигнуты сегодня немногими странами в мире. То есть это хорошие показатели, и которые должны задумывать многих и должны быть поучительными для других стран. Но сегодняшняя конференция собрала очень много гостей. Это гостей из 35 стран. Сегодня присутствует на нашем мероприятии господин посол. Именно руководителей Оли Маджлиса, то есть здесь руководитель центров, здесь все региональные учреждения.
Centers and provincial healthcare facilities. So all those people engaged in delivering the specialized care. This conference, I'm convinced, will be of great benefit for our TB care service. There will be room for exchange of experiences, knowledge, and it will be a new impetus for promoting innovations in this area. Dear colleagues, once again, I congratulate you on opening of this conference. Thank you. Thank you very much, Ulubek Yusufhanovich, for your support. Ulubek Yusufhanovich is Deputy Minister for Specialized Republican Centers, and we feel great support from him on behalf of the Ministry of Health, the leadership of our country, specifically for our TB care service. Now I'd like to give the next floor with great respect to Yelena Mikhailovna Borisova from the Legislative Chamber of Oli Majlis of the Republic of Uzbekistan, who is the chairperson of the Committee on Health Protection of Citizens of the Republic of Uzbekistan. Assalamu alaikum, dear participants of the conference, ladies and gentlemen. On behalf of the Legislative Chamber of Oli Majlis of the Republic of Uzbekistan, and on behalf of the Committee for Protection of the Health of our Citizens, I would like to welcome the participants of the International Scientific and Practical Conference titled The Foundations of the National TB Program, the Origins and Prospects of Innovations in Prevention, Diagnostics and Treatment, dedicated to the 100th anniversary of the Phthisiology Service of Uzbekistan and the 90th anniversary of the scientific and practical activities of the Center of Physiology and Pulmonology. Over the recent 6 years, one of the priority areas of government policy was a large-scale reform of the healthcare system of our country. And it brings its development to a new level. As a result of ongoing measures under direct guidance of President, our esteemed Shavkat Miramonovich Mirziyoyev, there's increases in effectiveness, quality, and convenience of care delivery to our population. We're achieving key parameters and goals of sustainable development of the United Nations Organization. I will remind you, Uzbekistan assumed commitments to implement 16 SDGs until 2030. The third goal is aimed at ensuring healthy lifestyles and assistance in providing well-being at any age. And it has 10 targets, and one of these targets is to reduce TB incidents in the population, and Uzbekistan has successfully been progressing. Since gaining independence, Uzbekistan has been taking measures to strengthen the health of the population. There is a legal and regulatory framework which is being improved from year to year. Currently, our country has 17 laws that directly concern the protection of health of our citizens, for international documents, and a number of codes and laws that regulate specific issues in the healthcare sector. I will remind you, in 2001, a law was adopted on protecting the people health from TB. And consecutive years, a number of amendments and additions were made to this law. It should be noted that during the anniversary period of the pediatrics service and during the independent years, we have been making strides in reducing the burden of TB in the country. Our country has formed a relatively new network or system of healthcare facilities that meets current requirements and that provide specialized high-tech medical care that is formed vertically, and it is brought closer to the population. And this care is of both surgical nature and also therapeutic nature. And this system of care delivered to our population is headed by the Republican Specialized Center for Tuberculosis and Pulmonology. The government support is provided to implement government and presidential decision, and that helps us to reduce key TB indicators. And we're proud to say that the incidence decreased by 1.5 to 2 times and mortality 6 times. And I should also mention a landmark event for the entire medical community and probably for the entire people of Uzbekistan. This is about an open dialogue that took place in March this year between the head of our state and medical community. On the 24th of March, an executive order of the president was adopted on measures to fulfill the objectives that were outlined during this open dialogue, and the roadmap was approved that includes 7 areas. And during this dialogue, we have specified each step for further development of our healthcare sector, including the development of specialized care service, and in this important area as TB control. You probably noticed that the agenda has a lot of presentations and reports on the establishment and development of TB care service in Uzbekistan. We can only say that enthusiasm and commitment to the profession of Uzbek TB doctors allowed the national TB program to be among the pioneers of the entire innovative process, from diagnostics and treatment regimens to video controlled treatment, or video observed treatment. So when you were entering into this conference hall, you've probably seen the newest technology that they use to provide TB care. First of all, this is X-ray diagnostics, which several years ago probably was part of science fiction ideas, but now it's a really working solution that helps us to exactly and accurately diagnose the patient and decide on the correct treatment. More than 140,000 lives were saved in the recent years, and this is your professional victory, and I would like to congratulate you on that. The International Scientific and Practical Anniversary Conference that is being held in our country is not only the evidence of prestige of this school in our country, but this is another evidence that we have achieved the global standards and providing care, and this is another impetus for further development of our country's research in science. This important event will become a platform where new recommendations will be developed for practitioners, doctors, to address relevant issues in physiatrics and pulmonology. And we as legislators are ready to provide all legal support to all the initiatives that will promote the development of this sphere, the great son of our land, that movement can replace many drugs. None of the drugs in the world can replace movement. These wise words are still relevant today. Movement, and this is an important element of healthy lifestyles. And movement in a broad sense of this word as moving forward, the progress, achievement of new results for the sake of lives and success of every human being. I wish the participants of this conference great success. And I hope that you will establish new and strengthen existing contacts. And I would like to welcome all the guests, all the participants of the conference who were able to come from foreign countries. And I hope that sharing experiences will be very useful. Serve to develop new approaches, new methods of treatment, which will bring closer the day when we will be able to say, well, just like my colleague said, tuberculosis has been, is here and will be, but we would like to see or live up to the moment when we will be able to say that we have eliminated tuberculosis. Well, at least that's the goal that we're trying to achieve. And using this opportunity, allow me to, from the bottom of my heart, to congratulate all healthcare workers with the coming professional holiday, the Day of Healthcare Workers, which, according to our legislation, is celebrated on the second Sunday of November. I wish everyone good and strong health and success in this work of creation. Thank you. Thank you very much, Yelena Mikhailovna, for your warm welcoming remarks. For our hard workers who are fighting this threatening infection from day to day and never being afraid of it. And we were convinced when COVID was in our country, TB doctors and pulmonologists were at the forefront of the combating COVID. Everyone was next to us, and our dear members of the parliament, that they were in the first ranks together with us, with the Ministry of Health, the entire healthcare sector. They were helping us to overcome this disease, and we almost achieved the victory. And the same will happen with TB. The next floor goes to the representative of WHO Regional Office for Europe, Askari Delbayev. He is a regional advisor on TB and drug-resistant tuberculosis in European region of WHO. Would like to welcome us on behalf of Hans Kluge. Hans Kluge is our big friend. He is the director of the WHO Regional Office for Europe. But for technical reasons, Hans was not able to be present here, so he asked Askar Delbayev to read his welcoming remarks.
Уважаемая Наргиза Нусратовна, уважаемые коллеги.
Dear Nargiza Nusratovna, colleagues, distinguished Deputy Health Minister of the Republic of Uzbekistan, dear Chair of Ali Majlis, the Parliament, Yelena Mikhailovna, thank you. Thank you for this opportunity to speak on behalf of WHO Regional Office for Europe. I would like to welcome you to this important event, and it's important not only to Uzbekistan but also at the regional level. So we welcome you to this scientific and practical conference on a very important landmark milestone, which is the anniversary of the Scientific and Practical TB and Pulmonology Center. And I would like to read the welcoming address on behalf of our regional director of WHO European Region, Dr. Hans Kluge.
Friends, on behalf of the WHO European Regional Office, I'd like to thank you for this opportunity and to welcome you to the International Conference, Fundamentals of Domestic Phthisiatry, the Creation and Prospects for Innovations in Prevention, Diagnosis and Treatment, marking the 19th anniversary of the National Scientific Center of Physiopulmonology of the Ministry of Health of Uzbekistan and dedicated to the 100th anniversary of the TB and Pulmonology Services of Uzbekistan and the 90th anniversary of the Center of Physiatry and Pulmonology of the country. Addressing tuberculosis is close to my heart, Throughout my professional career, striving to end TB has been there, always has, and always will. Prior to COVID-19, the WHO European region had the fastest decline in tuberculosis incidence and mortality in the world. Now, however, COVID-19 has changed the trajectory. We're off track when it comes to multi-drug resistant TB and TB-HIV co-infection. Late diagnosis remains a persistent challenge, especially in Eastern Europe and Central Asia. To renew our commitment, WHO Europe has developed a new tuberculosis action plan for the region, aiming for a leap towards ending tuberculosis and for addressing the impact on health in Europe by persistent gaps, uneven progress, COVID-19, and the war in Ukraine. We have an unfinished agenda and the number of urgent threats that need to be addressed simultaneously. There is no such a thing as a hierarchy of disease, and gaining the upper hand in the fight against the one disease can never come at the cost of losing a fight against another. Tuberculosis didn't disappear simply because we were busy fighting COVID-19. We face significant challenges, and the operational context has in many respects changed. That is why we need to work together harder to reach our goals before 2030. We need to dual-track approach to health, strengthening our current work and ensuring it isn't compromised even and anticipate and prepare for new challenges and emergencies that are escalating year after year. This is our new normal. The good news is that a month ago, the new tuberculosis action plan was endorsed by all 53 member states at the 72nd session of the Regional Committee for Europe in Tel Aviv, Israel. It is an honor for me to mention that this is in Uzbekistan in Central Asia a priority for tuberculosis and multi-drug resistant tuberculosis. Truth to be told, there are remarkable times for those of us working with tuberculosis. New technologies, approaches to treatment and care, rapid molecular diagnosis, shorter treatment for prevention and treatment, and innovative digital health solutions are reshaping tuberculosis response. We have the tools and preconditions to regain losses and step up our game. Central to those efforts and central to reach everyone living with tuberculosis with the care they need are partnerships between member states, donor agencies, civil society, and affected communities. We can reduce the burden of tuberculosis through partnerships. Increased funds are a far greater focus on tuberculosis is also vital. Dear friends and colleagues, when WHO Europe and its 53 member states adopted the 2020-2025 European Programme of Work, we committed all the more to leaving no one behind. There are not empty words. Leaving no one behind means health for all, irrespective of location, social status, and health issue. Health is a basic human right, and we owe it to the people we serve to do our utmost to help those most in need for health and social care. That includes those living with tuberculosis. I wish you a fruitful conference. Thank you. Dr. Hans Kluge. Thank you.
Спасибо большое.
Thank you so very much, Dr. Hans Kluge. Thank you, Dr. Askar Yedilbayev. And I'd like to say that the team of WHO European region has been in Uzbekistan for 2 weeks, and for 2 weeks we've been having NTP review. NTP review is the overview of the whole TB program, including, since we are an integrated service, so we include all the components, including primary health care and the related services. And as for findings of the NTP review, well, Askar Yedilbayev will deliver a special message on that. And I'd like to say that we are extremely grateful for WHO European Regional Office for their confidence in us, since Uzbekistan is the first country they have visited after the release of the new guidelines of WHO Regional Office for Europe. And yes, that's a great responsibility, and I hope it's also a victory for us. Yeah, thank you once again. And then I would like to give the floor to Mr. Paul Politis, Deputy Chief of Mission of the U.S. Embassy. The point is that, well, it's clear that TB is an infection that recognizes no borders, no ethnicities, no other differences, and definitely we are fighting it globally. But like, one country alone cannot combat TB, since this is an airborne infection which can cross all borders, and extensive support has been provided by international partners. Great support was provided by USAID and the US Embassy, so technical support to all our initiatives has been provided for more than 20 years, and we can witness that enthusiasm and that openness, sincere attitude with which they help us fight TB. So the floor is yours. Thank you.
Deputy Minister Sabirov, Director of the National Tuberculosis Program, Professor Parpieva, Chairperson Borisova, Dr. Yadulbayev, Dr. Mosneg, Dr. Latichevsky, Dr. Nyangwa, ladies and gentlemen, дорогие участники, уважаемые.
Dear participants, good morning.
This morning to celebrate 100 years of tuberculosis services in Uzbekistan, as well as the 90th birthday of the Republican Specialized Scientific and Practical Medical Center of Phthisiology and Pulmonology. And we commend Professor Parpieva and her team for their leadership across facilities, systems, and communities to build upon 100 years of service to Uzbekistan's people to reach, cure, and prevent tuberculosis. The U.S. Agency for International Development leads the United States government's efforts around the world and has been a long-term partner of Uzbekistan's national TB program. This partnership between USAID and the National TB Program has strengthened the continuum of TB services, starting with TB awareness and prevention messaging, testing and diagnostics, and treatment and care of patients with tuberculosis. In addition, supporting the many health systems that are the foundation of good services is critical. USAID TB partners have worked with the National TB Program to strengthen management, financing, workforce capacity, and information systems. USAID is also alongside the National TB Program as it develops new ways to combat multi-drug resistant tuberculosis. We do this by scaling up evidence-based TB interventions, such as modified shorter treatment regimens or new TB drugs. One example of USAID's support is the improvement of TB diagnostics by providing labs with much-needed GenExpert machines. These machines provide a client with his or her TB diagnosis in about 2 hours, down from a 2-week waiting period using previous microscope-based tests. Faster diagnosis and notification mean that TB-infected individuals are notified and can initiate TB treatment more quickly. Later this morning, during the coffee break, USAID will hand over and demonstrate a new innovation in TB screening in Uzbekistan, portable X-ray machines. These devices are battery-operated, fit into backpacks, and will bring TB screening services to communities living in remote areas. So I now want to present Dr. Parpieva, Professor Parpieva, to you. It's my privilege to present to you. I've always wanted to hand over one of these giant certificates, so it's not a check, but it's a big certificate. So Professor Parpieva, I'm honored. So once again, we congratulate you, Professor Parpieva, and your team at the National TB Program on 100 years of TB services to your country. I also want to thank all of USAID's implementing partners who make all of our great work here possible. Thank you very much.
Thank you very much, Mr. Paul. Спасибо большое.
Well, thank you so very much to our partners. And actually, in our country, we have 122 GenExpert machines, out of which 22 already detect resistance to 6 drugs. Immediately, in 2 hours, we can diagnose XDR TB. And today, there has been donation of new ultra-portable X-ray machines, and actually we handed them over to Tashkent City TB and Pulmonology Center. They have piloted them, and in fact they have started working, so they could help with the screening of our population, AI-based machines. And in fact, even there is no need for doctors to diagnose patients, and you will be able to see those machines. They will be displayed outdoors. And the next floor is given to Stop TB Partnership. So Ms. Dito was supposed to come to the country, but for technical reasons she canceled her trip, but she sent her video message, and we will see it now.
Good morning, Luchika. We listen you, please.
Dear colleagues and friends, thank you for inviting me to speak and to share a few thoughts with you in the beginning of what I think will be an amazing meeting. I wish I could be there with you, and I promise that I will come back in Uzbekistan, but I also promise to take care of all of you coming to Geneva to meet together. The European region needs champions in ending tuberculosis, and I think the efforts that the Uzbekistan government, Ministry of Health, and NTP manager specifically are remarkable. I'm very happy that you constructed at the end of the program review an international conference looking at also a lot of new tools, a lot of innovations going forward. And as you know, we at Stop TB Partnership are always pioneering interventions that are really putting TB at the forefront of the fight, but also increase our chances to end TB. My two messages that I want to leave are, one is to really underline the fact that I think the Uzbekistan program is on the right path and also on the right approach by looking at the links of the TB program and interaction and with the universal health coverage, and making sure that TB is part of this entire reform and conversation is crucial. Tuberculosis is a very good metric for universal health coverage. As you know, the people with TB are having a lot of other vulnerabilities, and the moment they are reached with services for diagnosis of TB, for contact tracing, for preventive treatment, for treatment, I could say that that can be a very good metric for reaching universal health coverage. So that's why please continue in these efforts, and please make sure that TB is part of this conversation. The second part that I want to make is that we will need very much the leadership of Uzbekistan to stand up for certain things that can be done much better in TB. I had the chance to interact in the margins of the WHO regional committee with the leadership in the Ministry of Health about having a very strong investment case for TB in the country, for having as well very strong thinking of learning and using things that were done for COVID to be used for TB. Both TB and COVID are two airborne diseases. You know, there are a lot of discussions on preparedness and response for airborne diseases. TB should be there. We should be smart going forward in using what we learned from COVID to address TB and vice versa. And one of the things very important to do is really trying to enlarge diagnosis by multiplexing and by trying to diagnose not just tuberculosis but other diseases as well, basically using tools that identify multiple diseases, being them infectious diseases or not, in the same time. So I know that you will have conversations around mobile X-ray, portable X-ray, artificial intelligence. As you know, from Stop TB Partnership for the last 4 years, we pushed the conversation around these topics and around these tools. So we are very happy that we are at the moment in which, with the help of some of our donors, we can have in Uzbekistan and in several other countries in the European region, this kind of tools. I will stop here. I think the idea that we should have, or the plans that we should have to end TB by 2030 should be anchored on the fact that every single person that is affected by TB should receive the same standard of care, quality, and access to the latest WHO recommended tools and interventions. And we should have plans that are budgeting for this and that are including this, not just by some groups or subpopulations, but for everybody. I wish you amazing days ahead, amazing conversations, and I miss you all. I miss a hug with you all, but promise to do that very soon, either in Geneva, either in Tashkent, or somewhere around the world. Thank you very much.
Thank you very much, Luchika.
I am very grateful to all our partners, and even if they couldn't come here, they provided video messages at least. And now I would like to give the next floor to the partner who could make it to our country, a representative of International Humanitarian Agency, Doctors Without Borders, MSF. Dr. Beren Thomas. Actually, MSF has been working in Uzbekistan since 1999, and it is my pleasure to recall that Dr. Hans Kluge also started his work in Karakalpakstan jointly with MSF. He combated TB there in the times where we definitely had the crisis, environmental crisis in the RLC area. And today, I have to say that jointly with MSF, we are not only working hand in hand when combating TB, but all together we also are doing scientific randomized trials, and I will give you more information on that later. But now I would like to give the floor to our big friend from London, Beren Thomas. So, floor is yours, please.
Deputy Minister and Chair of the Committee on Health Protection and Empowerment. Ladies and gentlemen, friends and colleagues, I would like to take this opportunity to thank you for inviting me to this prestigious event, and congratulations to you all on the 100th anniversary of the TB service in Uzbekistan and the 90th anniversary of the Scientific Center of Physiology and Pulmonology. We as MSF, we're proud that of those 90 years, we've been partnering with you for at least 20 years and more than that. It's great to see that such rich and important history, the TB scientific community of Uzbekistan is changing along with progress, implementing innovations and contributing to the development of global practices of TB treatment. Over the last 5 years, the Ministry of Health of Uzbekistan and MSF have worked together within the global clinical trial TB Practical to achieve successful results. Together, we have found a new treatment for drug-resistant TB that is not only safe and provides new opportunities, but also makes the patient's life significantly easier, and it is cheaper and much easier for the TB services to provide as well. Firstly, due to the period of treatment, this only 6 months compared to the 2 years or more, and also it's all oral regimen, they're no longer injectables. The results of the clinical trial show that the new treatment was effective in 9 out of 10 patients. Today, we announce a new step, the SMART operational research, to continue providing the 6 months TB treatment to patients. We are positive that it will very soon become the standard of care in Uzbekistan and, of course, all over the world. The World Health Organization already announced that in the near future, the TB treatment scheme will be included in the updated guidelines for the treatment of TB. So this short 6 months regimen is a regimen that the clinicians, the nurses, the healthcare workers and the population of Uzbekistan have gifted to the world. This is a significant achievement. This is a significant step. And of course, what we would ask is for sure that this gift that the people of Uzbekistan has gifted to the world should be accessed by the people of Uzbekistan. Each an individual who needs this treatment is able to access it soon, and as many of them as possible. So I also have a symbolic gift, a symbolic gesture, I'll say, to Professor Papiva. So I'll hand over this symbolic gesture, which is a key, which I'd like to hand over, and it symbolizes a way forward in which the Professor Papiva, your teams, and MSF can work together to really unlock this devastating illness. Thank you.
Thank you so much, Mr. Ben Thomas. This symbolic key is the beginning of a new randomized research operational study. It is symbolic that today it was handed over on the day when we're conducting the celebrative event to commemorate the 90th anniversary of our service. Now I would like to propose to you a video about the history of our TB service, the history of our center. Please pay attention to the screen. The first TB room and then dispenser was organized. These are directors for the university, of this institute. Sorry. This is the development of the service from 1930 to 1940. From the 1940s, the institute employed one candidate of medical sciences and 9 researchers. Different research was conducted in epidemiology, pathogenesis, and prevention of tuberculosis, and started in the 1940s under the guidance of Professor Alimov. Annually, the Research Institute and the teaching chair of tuberculosis prepared 40 to 50 TB doctors. In 1943, the Institute organized a biochemistry lab. In 1947, the microbiology lab. In 1957, the pathophysiological lab. There are 25 dispensaries in 1950s, and the number of beds increased 4 times. Fundamental research was conducted from 1965 to 1970 at the institute, and they had applied value, and there was also issues that related to medical rehabilitation that were studied. And ultrasound aerosols with and the bronchial catheterization and for peripheral bronchs under
X-ray control was carried out. In 1980s, the researchers of Uzbekistan conducted fundamental research to identify different immunities and to be of the lungs. Highly effective technical ways to interact with surgery were identified in pathologies of urological TB, and also surgeries on the spine were conducted. Formula system tuberculosis and translation of Dr. Crawford's book into in Uzbek was published. In 1996, the news bulletin of the Association of Pulmonologists started its issue, and there have been 14 issues since then. With the years of independence, the center's staff published all the monographies and theses and articles. Structural Center now currently has 4 scientific departments and 40 researchers and doctors, 10 doctors of sciences work for the center. Over the years of independence, the center has conducted 9 scientific and practical conferences with international participation. To international congresses, the Congress of Allergologists and Pulmonologists in Central Asia, the 4th Congress of Eurasian Respiratory Society, and 5th Congress of Pulmonologists in Central Asia. 2 anniversary conferences, 1 inter-republican meeting for Central Asia, and 3 scientific sessions, and 12 visits to foreign countries.
The key areas of research currently are improvement of diagnostics, comprehensive treatment of multi-drug TB forms, and other areas. New stage of reforming the TB program in Uzbekistan. This is counseling balcony. Radiological diagnostics department. ICU. And the bed capacity of the Republican Center for Tuberculosis and Pulmonology. It's a national reference laboratory. The Department for Pleural and Lung Surgery. And also, the center has bone and joint tuberculosis department that performs surgeries. More than 200 high-tech surgeries are conducted at urogenital TB department, pulmonology department, the department for treatment of pulmonary TB, the Center for Innovative Distance Education and Monitoring, international collaboration that happens at treatment department number 2. Address and location. We apologize if there were some technical difficulties happened during the video, but we would like all of you sitting here in conference room see yourselves young on these photos. I think this is the history that will continue. And then the next video will be shot professionally. Well, this was, we created this video with USAID and EDICA. We decided to remember because today is the 100 years that our service has been working. And I will give the next floor to myself. Dear friends, I worry a lot today, but those who know me don't know that I don't usually worry. But today is a day filled with feelings because this is the anniversary. I would like to speak about our service, about 90 years of our service. And this is an honor that I have today, and I'm thankful to God and to the leadership of the country who trusted in the fact that a lady can be heading this service. And I would like to speak about the implementation of our national TB program in the Republic of Uzbekistan, achievements and further goals. I'd like to remind you that our country is not that large. The area is only 449,000 square kilometers, but the population by 2022, while in the beginning of 2022, was 35,271,000. But right now, the number of our citizens is increasing. On the day of the conference, when I speak about our service, I'd like to remember about the milestones on our way. Our institute was created in 1932, according to the decision of the Collegium of the National Commissariat of Healthcare of the Uzbek SSR on 21st of November 1932. It was the second category research institute. The scientific profile of the institute was improvement of organizational form of TB control work in agricultural districts of our country. Also researching the methods of pathogenetic and simulating therapy, also in case of side effects and lack of tolerance to TB drugs, and the comprehensive development of rehabilitation measures for TB patients. Our modern specialized Republican Scientific and Practical Medical Center was founded on the basis of the institute in 2009 through a presidential decree dating to 2007. The key priorities for TB control in Uzbekistan were, first of all, to ensure universal access to early detection and diagnostics of tuberculosis. Back then, we started detecting sensitivity to drugs, ensuring universal access to quality treatment of all form tuberculosis. That was people-centered. Also, increasing access with preventive treatment of TB with a focus on persons from pockets of infections and people living with HIV, increasing access of key population to comprehensive preventive services, treatment services,
and ensuring effective prevention, diagnosis, and treatment and care for patients by providing a conducive environment. And definitely when informing you on the anniversary of the service and the center, first of all, I'd like to now academician Alimov, and yesterday at our center we opened the board which we showed in our video, and I was pleased to do that jointly with the daughter and the grandson of Professor Alimov, and I know his grandson is here with us. And when speaking about the originator of the TB service, Professor Alimov, actually he became the Doctor of Sciences in 1951, Professor in 1953, and academician in 1974. And in 1964, he received the award as the scientist of Uzbekistan, and during the World War II, he received the medal. And for his successes in scientific and practical activities in 1951, he also received the medal, and so he led 6 doctoral theses. And for the first time in Soviet Union, he initiated in Namangan province the establishment of the curative sanatorium. And in fact, the patients received not only treatment and rehabilitation there, but they also could master more than 20 occupations there. And that sanatorium was the model for organization of rehabilitative treatment for other Soviet republics. After Shakir Alimovich, we had Professor Abdunabi Kalam Hadjayev. And until 1986, he led our center, and he was the founder of endocrinological focus on TB care, and he organized the first laboratory of radioisotope diagnosis for the first time in Central Asia and TB facilities. He received various awards and medals, and 4 doctoral theses and 18 PhD and doctoral science theses were developed under his leadership, and he is the author of more than 150 scientific works on epidemiology, diagnosis, differential diagnosis, and TB treatment. He initiated comparison of the TB epidemiology in rural areas, and he also studied the effects of pesticides on TB incidents, and from 1986 to 2010, the director of our center was Abdullah Obaidullah. He is the founder of the pulmonological science in Uzbekistan. He established the scientific school of pulmonology. So he is still working. He is leading the development of PhD works and thesis, and so he is a doctor of medical science since 1974 and the member of the Academy of Sciences since 1995. He was recognized in 2004 as the best specialist of Uzbekistan, and he received his award, the best doctor of the year. He initiated the Association of Pulmonologists in Central Asia, and that was established at the first Congress of Pulmonologists and Allergologists of Central Asia in Tashkent in 1994. This association is still operating. He initiated epidemiological studies for early TB detection, and also he worked to improve performance of the TB service. Uzbekistan became the first country in CIS where dispensary observation of TB cases was optimized. After him, the director was Professor Mirzagaliev Teleshaykhov. He is a doctor of medical sciences professor, and the decree of the President of the Republic of Uzbekistan as of 2017 awarded him with the State Award for the achievements in science and technology, establishment of fundamental frameworks to improve the TB care for the population. He is the author and co-author of more than 400 scientific works, including 3 monographs and 10 methodological recommendations for doctors, master's level students, and those receiving residency trainings, interns, and since 2011 to 2015, he was the head of the state program to combat TB in Uzbekistan. Well, I will later inform you that that was the revolutionary program initiated by the then Prime Minister of our country, Mirziyoyev Shavkat Miramonovich, and in fact, in that period, Professor Teleshaykhov led our service, and revolutionary changes occurred, and I will inform you on them later. Mirzagaliev Nigmatovich, for the first time among the countries of the European region, developed the uniform order. So that was for the first case when Uzbekistan developed that uniform order. We revised all legal and regulatory documents. We canceled more than 20 outdated orders and legal documents, and we developed the single uniform order for the whole service, which was titled "The Improvement of Anti-TB Activities in the Republic of Uzbekistan." And definitely he contributed extensively to the establishment of the reconstructive rehabilitative surgery for cases of pulmonary and extrapulmonary TB. Rapid diagnostics labs were established throughout the countries. They were well equipped with laboratory equipment, and also he ensured 100% supplies of anti-TB drugs. And after, in January 2016, he was appointed as the director of the Republican Center for Cancer Care and Radiology starting the 5th of February. I've been running this center, and in fact that was a great privilege for me, and I'd like to say that, well, maybe I will skip this information about myself, so you better take a look at our activities. So this is the whole leadership of our center, deputy directors on various areas, and actually another position was established by the presidential decree, deputy director for the work in provinces. Khairullah Rajapov is running this area, and we are doing a lot to implement the objectives set before the center by our distinguished president. So the population needs to have access to high-end, sophisticated, specialized care, and for that he shouldn't come to Tashkent. So in all our provinces, at the provincial level, we established those conditions so population could approach those facilities for these sophisticated healthcare services. And now we are going down to districts, and I can proudly mention that in densely populated areas, such equipment was installed as gene expert machines and various other pieces of equipment, and in fact, some sophisticated surgeries are performed in those areas, and when going to provinces, we provide such care. While discussing our center, well, we can show you that we have 11 wards or departments and laboratories. Well, I can brief you on that, and actually we would like to show you how X-ray was done long ago. And it can also mention that today, but now the center has all the equipment produced by Siemens, computerized tomography, CRR, and various ultrasound devices. So now we have received the ultra-portable X-ray machine, and definitely we will use it for our population. And most importantly, all the support is provided free of charge. So the equipment, well, actually, jointly with Professor Teleshaykhov and our team, we won the big grant worth 3 million from KfW Bank, and as a result, we managed to equip our center. And please take a look at how the tests were done before for breathing function, some aerosol-related procedures, and you see how the service is established now at our center, and some images on how the service was organized before and now. We have a lot of equipment, and definitely it makes it way easier to diagnose patients. So you can see Professor Kazakov Konstantin, who led our biochemical lab. He was our teacher, mentor, and he also was he helped us develop our thesis. And in fact, now we have well-equipped laboratories, and we have also equipment produced by Karl Stolz, endoscopy laboratory equipment which we use when we do surgeries on all organs and symptoms. And we are immensely grateful to Shavkat Miramonovich Mirziyayev, because it took just 9 months to carry out the whole reconstruction of our center, and you can see that our center still remains modern, and it meets all the requirements. And I would like to highlight the important milestones of the TB control programs. And I'd like to say that we initiated reforms in 1998. In 2001, the law was adopted, and it was mentioned by Yelena Mikhailovna. It's the law adopted by the president on protection of the population against TB. So we decentralized the TB care. So in each and every rural outpatient center, we established the sputum collection sites, and also we had the so-called DOT corners, where drugs were not just distributed to our patients, but that was done under direct supervision of health professionals. And the fundamental change was the resolution number 62 for 5 years. Next, we had the resolution for 191, and the Shavkat Miromonovich signed it in 2019. I will tell you later about that resolution of the president. And now we have the new one, so we receive the status of the PR. So we are the primary recipient of the Global Fund, our center, our service, and it's all done within our national TB program. We have well-established operations, and I'd like to show you the rates which we found in our archive as of 1965. So you see, they divided it also by 100,000 population, and you see 1965 in the city, in the urban area, we had 186. In rural areas, it's 108. Overall, 135. In 1967, you see the relevant rates. And as for rates in children, in 1965, overall 77. In 67, it's overall rate 75. As for mortality, 65, 38, and you can imagine. And now please take a look at this very table where we are showing the activities underway in our country. So in early 2000s, like elsewhere, the problem of TB was critical, and the incidence was 79, and in Karakalpakstan it was 183, but that's the area of environmental disaster. And take a look at the mortality. So in 2002 it's 12.3 and 39 in Karakalpakstan, and back then we started receiving support from our partners, MSF. They started working in Karakalpakstan, and the latest rates in 2021, the incidence 35.2. And take a look at mortality. It's only 1 per 100,000 people. And these data are reliable, and it suggests that extensive activities are carried out in our country. Once again, why we have reached such results? Because we have the program-based approach, because we have the political commitment, and you can see that the resolution number 62 of the Cabinet of Ministers of the Republic of Uzbekistan for 2011 to 2015, and the next resolution of the President, which was issued on the 13th of February in 2019, on measures to improve the specialized TB and pulmonology service. So you see, based on resolution number 62, which was issued on the 5th of March 2011, since the 1st of April 2011, all personnel and TB service received bonuses on top of their salaries, 50% up. And in 2011 to 2015, so $110 million back then was the allocation from the government on the reconstruction of more than 40 TB facilities, and they all were reconstructed in line with infection control requirements. So we conducted the improvement of the equipment status of our service. So in 2010, when we only started with Professor Tilashekov, the equipment status was only 52%. 5 years later, that rate reached 83%. And over that time, we trained a lot of professionals. We upgraded them. And definitely the fundamental legal document was the Uniform Prikaz order. So this is a set of legal documents in the area of TB control. And in line with Resolution 4191, and yesterday we talked about that with representatives of WHO Regional Office for Europe. So it was issued in February 2019, and then on the 1st of April 2019. The order of the Ministry of Health number 90 improved the procedure, number 89, I'm sorry, improved the group of people exposed to higher risk of TB infection. So in line with WHO recommendations. And then the order of the Minister number 90 approved the procedures for delivery of pulmonological services. And Resolution of the Cabinet of Ministers number 678 established streamlined procedures for importation and registration of test kits, diagnostic kits, and also anti-TB drugs with WHO certificates. And in line with the most recent recommendations of WHO in 2020-2021, we updated the national treatment diagnostic protocols. And take a look, we changed the paradigm. We don't only detect the infection, we also enhance the prevention. So we started detection of LTBI and chemo prevention, and we also introduced video supported treatment in 2020-2022. More than 1,000 TB doctors and pediatric TB doctors received advanced training in updated standards. And we have the unique 5-tier laboratory structure, which was established in line with Resolution 62. But as a result of subsequent developments, you can see that this 5-tier remain unchanged. But level 1, the primary health care, level 2, provincial bacteriology labs, level 3, unique inter-district bacteriology labs were set up. And at level 4, back then we had only the perfectly equipped laboratory equipped by MSF Nukus, and now we also have the lab in Samarkand. And level 5, this is our national reference lab. And in the country, as I said before, we have more than 122 gene expert machines, 17 backtech machines, and they make it possible to avoid 2 or 3 months waiting time, and we can get the results in 2 weeks. And also we have hind tests that help us identify the susceptibility, and in addition to the global fund, from which we have received almost all the drugs starting 2017 to 2018, and in 2019-2020 in full-fledged mode of government funds have been allocated to procure first-line drugs and partially second-line drugs. And we can proudly say that Uzbekistan is so far the only country in the region, at least now, where procurement is done from the state budget only via GDF. So this is quality assured pre-qualified WHO pre-qualified drugs. And the achievements also include surveillance. We are piloting the new electronic system recommended by WHO. This is DHIS2. On top of that, we also piloted the new methodology for LTBI detection with verification up to 99%. This is quantiferon test, quantiferon TB Gold. And now in our country, we already started receiving the first 10,000 samples, and we will continue to do so.
And our country will be doing the testing using quantiferon to identify LTBI. And you probably are now convinced that we're piloting and will continue rolling out the implementation on the TFOC grant that we won for portable X-ray machines with built-in artificial intelligence software. And of course, operational studies for treatment of TB. For the first time, our center has won several international grants on our own, and the newest and novel treatment methodologies are being implemented on the country. Video-supported treatment. We launched it in Navoi province in 2019. You know that the distances between districts are huge. So what is it? And with the help of our partners, UCD and the Global Fund, we purchased smartphones for our patients with built-in internet-based software, and supervising doctors were procured tablets, and patients take drugs at home, and this is a video supported or video observed procedure. And a platform was created on the basis of software developed in Moldova with our partners NGO Intelation. The achievements of the programs are evident through these figures. So drug-sensitive TB treatment was 85% according to WHO targets. Now in Uzbekistan, we achieved 91.2. The successful treatment of MDR-TB, this is something that where we need improvement. It's 69.7 right now. The treatment success of XDR-TB is 56.3. But the most important figure is this one. From 2014 to 2021, Uzbekistan saved more than 120,000 lives. So this is one of the most important indicators. And success of treatment with our shorter regimens, and starting in 2020 of drug-resistant TB is 85.7, the treatment success rate. Uzbekistan with Belarus and South Africa is participating in randomized trials, experiments in TB practical. The first site was opened in Nukus in 2016. In 2018, we opened up the second site in our center. These are the results which I'm going to briefly talk about. I would like to say that Uzbekistan is the country, along with the partners, has proclaimed that the 6-month courses for treatment of drug-resistant TB instead of 24 months have produced excellent results, and you can see here that the treatment success is up to 89%. And international collaboration on the 12th of April 2018, together with Harry Robbins, then the director of USAID in Uzbekistan, we opened the Center for Innovative and Remote Education and Monitoring in 7 regions of our country first, and then we rolled out to more countries. Then Alan Meltzer is awarding our deputy minister then a memorandum for the next 5 years, and we hope that the work with USAID will continue for many more years. Please take now on the 11th of February 2020, the biennial agreement on collaboration was signed. Hans Kluge, Teresa Kasaeva was from WHO headquarters were here, and they visited our center, and so the opportunities created in our country. And of course, we are conducting a lot of conferences with our partners where we cover all the questions. And here you can see the ambassador of the United States, Mr. Rosenblum, who was personally participating in the conference, just as Ms. Ambassador Ms. Bratlin, who took part in our TB control events. There were many addresses in mass media by our TB program where we raised awareness of our general public about TB. And there was a significant contribution by us during the COVID pandemic when we appeared on TV and consulted our patients in the open dialogue mode. And on the last slide, you can see the targets of the strategy and TB until 2025. We have quite ambitious goals ahead of us, but I'm confident that we will achieve them together. Thank you for your attention. And right away, I would like to say that according to our agenda, we are going to honor the veterans of our service. So we will try to do it quicker and in order to be able to follow our schedule. Dear colleagues, there is with great respect and esteem, I'd like to welcome our veterans. Irina Vladimirovna and I, we understand that we've been We've worked for many years, just like Verigor, we've worked for many years within our service, but we're trying to be the forefront of our service. And I would like to honor our veterans who were able to come here. And it's a great pleasure for me to to call their names so that they could feel all the respect we feel for them, even though maybe for a very short time, but still. But the first on the list is Abdullah Mukharovich Ubaidullayev, but unfortunately he fell ill and he was not able to come here. Abdulwahid Sadikovich, our veteran, who for many years has worked in TB control. I will just call out your names. We have prepared gifts for you, and our helpers will bring them to you so that you don't have to come. Pitaya Irina Vladimirovna, our scientific secretary. She was not able to come. She was at our center, and we were opening our memorial board for Shakir Alimovich. She was there, but she's not present here. Kurbanova Rano Rahmanovna is our surgeon. Rano Rahmanov, could you please stand up so that everyone could see you? Rano Rahmanovna inspired me to become the chair of the teaching department on TB at the Tashkent Medical Institute, and she worked in the first ranks in Karakalpakstan together with MSF. Thank you very much, Rano Rahmanova. Mukhtar Davronbek Zukhurovich. He should be in the conference room. Davron Zukhurovich. For many years, Davron Zukhurovich. You have the loudest round of applause. You have been Deputy Director for Research, and now you are the head of the Teaching Department at the Teaching Department for TB at the Postgraduate Medical Education Institute. Yakubekov Tahir Yunusovich. All his life, he dedicated to TB control, starting from Tashkent Provincial TB Dispensary. And then for many years, he had the first city TB hospital, and currently he's one of my advisors at our TB and Pulmonology Center, but he's in the first ranks in TB control. Khadjayeva Mavluda Inagamovna. Khadjayeva Mavluda Inagamovna is currently still is our chief or supervisor of all the professors at our teaching department. She's in charge of the educational sector of the teaching department on TB, Tashkent Medical Academy, the Academy of Sciences, Associate Professor Mavluda Inagamova. Nazirov Perimkul Khajamovich. I think that you'll have a very loud round of applause because Perimkul Khajamovich dedicated his life to physiatrics. He's been for many years in charge of bone and joint TB department. In Uzbek, it's called, you have a lot of people who would like to invite you. And he goes to all of our provinces to perform the most difficult surgeries. And I would like to wish you more professional success. Drizaeva Delarom Shakirovna. I saw you coming, Delarom. Thank you so much. She devoted her life to physiatrics. Rahmanov Shafkat Rafikovich. I'm calling out the names of the veterans who have only one line in their employment records, but they were within the TB service. They might have changed some places, but they stand within the TB service. Ismatullayeva Khursan Kundratullayevna. Khursan Kundratullayevna is the elder of our TB control service, and several years ago, we went with her to a training to Almaty. At some point, I thought, what am I doing? I'm taking on this responsibility, taking her care. But she was always ahead of me, even wearing heels. He was the fastest. Please continue educating our young specialist, Tilaeva Muhabbat Nasridinovna. She's been for many years a physician who worked within our service. Thank you so much. Mamedova Mohinur Ismailovna, my first head of the department, who also taught me the practical aspects of my work. Abadieva Tatiana Muratovna, also one of our veterans who is present here. I received a message. Vladimir Vladimirovich Balabulov is here. Where is he? Thank you so much. I have great respect for him. In 2020, he was awarded a very high prize from our government. He received an award for his contribution not only into development of the TB control, but also for building friendly relations in different areas of our health sector. For many years, he was in charge of our clinic in Fergana province, and Vladimir Vladimirovich is on the post. He's still in action, and we hope that for many years you will be doing your job, that post. Unfortunately, not all of the veterans were listed here who came from the provinces. But even without calling your names, but I would like to bow down to you and thank you that for many years you didn't spare yourself and devoted your lives to this very serious cause, and have done a huge contribution to TB control in the Republic of Uzbekistan. And we've prepared gifts for you, and during the break, my assistants will hand out those gifts to you. Thank you so much. I have a dry throat because I'm so worried. Now, everyone is invited for a group photo. After group photo, we'll have a coffee break and a press conference.
Уважаемые коллеги, мы вас приглашаем на кофе-брейк, а потом я хотела бы сказать, что в этом зале будет первая пленарная сессия, это партнерство во внедрении глобальной стратегии по туберкулезу, и параллельно в 3 залах у нас будут секционные заседания. Информацию наши коллеги вам дадут, у вас на руках у всех есть где размещение этих залов. Сейчас мою сумку посмотришь. Елена Михайловна.
The announcement was made that the first session is going to be conducted here in Amir Timur conference room, and there will be several more sections in different halls of this hotel, and my assistants will take you to those halls based on your interests.
Да, идем, Елена.
you are ready to absorb information, I think we will start. However, the delegation from Kazakhstan approached me with a request. I think that we need to help them. Request from my friend, the director of the Center TB issues, Malik Moldabekovich Adenov. For certain reasons, he was not able to be present during our conference, but he passed on his congratulations and some presents for our service. Good morning, dear colleagues. Allow me to welcome you on behalf of the National Research Center of Pulmonology on the Republic of Kazakhstan and congratulate you on this anniversary. Unfortunately, our director, Mr. Adenov, was not able to come here, and I'm passing the decision of our center as the honorable member of our institution. Thank you so much. This is very touching. Thank you very much for recognition of this kind. But I think that applies not only to me, but to our entire TB control service. Thank you so much once again. I know that they recently celebrated their anniversary, but I was not able to participate, unfortunately. Our team members did participate and conveyed our congratulations to your center, to the entire team that is working to control TB in Kazakhstan. I'm sincerely grateful to you. Now I'd like to announce that we're moving on to our plenary session that is called Partnership in the Implementation of the Global TB Strategy. And the first presentation will be done, and I'm giving him the floor with great respect. He's going to speak about TB Action Plan for the WHO region, European region 2023-2030, intensifying efforts to end TB. Please, you have the floor. Dear and esteemed Nargiz Nusratov, dear friends, colleagues, allow me to once again thank you for an excellent opportunity to take part in this international conference, and I'd like to also greet you on behalf of our colleagues from the WHO Regional Office for Europe, who for many years have been working hand to hand with you, side by side with you, to help you reach your goals. I would like to thank not only on behalf of the WHO Regional Office for Europe, but also the country office and the headquarters of WHO, and send the best regards to the National TB program in the Republic of Uzbekistan. Allow me to tell you about a new strategic plan that was quite recently, a month ago, was adopted by a majority of vote by member countries of the WHO European region on the second session of the European Committee of the World Health Organization. And first of all, why is this document, why was it developed? and why is it necessary? I would like to give you a brief introduction about this. The progress in implementing regional targets and regional commitments in our WHO European region, which includes 53 states, member states, was to reduce incidents and number of deaths from TB.
So that was reached. Actually, in terms of incidents, the target was identified by the previous TB action plan for 2016 to 2020, and actually a 25 reduction by 2020 compared to rates of 2015. That was reached, and we even exceeded that target. And as for the reduction in the number of TB deaths, if we compare 2015 to 2020, then the decrease accounts for 26% because the target was 35 and we failed to meet that target, mostly due to COVID-19 pandemic. And definitely one of the challenges in our WHO European region is the burden of drug-resistant TB, and most of the burden of DRTB in our European region is in Eastern European and Central Asia countries, and 9 of those countries are listed here, and they are on the global list of countries with high burden of drug-resistant TB. And I'd like to note that for a variety of reasons, and given that in our WHO European region countries, we have well-established diagnostics for TB patients and DRTB patients, and that's why we report quite a few cases. But actually, a quarter of those, 26% of the global burden of DRTB cases is in European regional countries. And if we discuss MDR TB patients with resistance to fluoroquinolones, then the global burden is 50%. Well, almost 50%, 47% is reported in our European region countries. Unfortunately, drug-resistant TB still is difficult to treat, and the success rate as of 2018 for this type of patients is 56%, which is way lower than the 75%, the global target, and as for XDR-TB treatment success rate is even lower, it's 51%. Another challenge towards the progress is increasing HIV infection rates, and definitely the co-infection when we have TB plus HIV, we can see that increase in the last years, and in fact in the last 10 years the TB HIV rate has almost doubled. And in 2018 to 2020 the share of new cases, new HIV cases among TB patients is 12%, and we know that it's quite a lot. And in fact, the risks in that case for treatment failure and death are way higher. And as in addition to the existing burden which we have in our region, which I've mentioned before, we can see strong effects of the COVID-19 in terms of reaching our global targets. And we all can remember that in 2020, when the pandemic only started, many countries were introducing lockdowns, they restricted movement of people, and all resources of healthcare systems were rechanneled towards response to COVID-19. And Nargiza perfectly mentioned in her presentation that it was the TB and Pulmonology Center that and the service that worked on the front line combating COVID-19, and that's why we are extremely grateful to you for all your contribution. But anyway, the COVID-19 pandemic resulted in the fact that the number of reported TB cases in 2020 compared to the similar period in 2019 went down, but the average reduction is 24%. So there were various models used, and it suggests that this temporary reduction in the number of reported cases over a specified period of time, well, 25% over 3 months, can result in increasing mortality rates, because there will be delayed diagnosis and no adequate treatment will be prescribed timely, and in fact treatment will not be organized timely in that case. And that's why in WHO European region in 2020 we can state that we had the drop in the number of reported cases, and in European region this is lower than the global rate, so it accounts for 24% in 2020 compared to 2019, and respectively, as I said before. And so last year, based on the global TB report, you could see these rates. So now we have higher mortality, more fatal cases among TB HIV patients, and you can take a look at the right side of this slide. So what I'm saying is that on top of the burden of COVID-19, it's also an important factor which actually encouraged us, as requested by other countries, to develop this regional document, which offers a new vision, how we need to work in new settings, how we can progress towards our goals. Another challenge is challenging geopolitical situation. You all are aware of the war in Ukraine, and we would like to state that this is happening now, and it has a negative impact on the status of health systems, on care delivery mechanisms in Ukraine, and on TB care provided to TB patients in need of it. And health professionals also are moving inside the country, in-country migration, and also sometimes they have to leave the country. They are in Europe, many of them, and it results in humanitarian crisis. And countries of the European Union bordering on Ukraine currently see a great inflow of refugees, and among them we might have TB patients. And that's why the issue of the TB burden in our region, namely DR TB burden, in the absence of appropriately organized care and interruption in treatment, well, it all can impede the progress. And this is another challenge which we are facing in our region, given the fact that we also have enough new opportunities. We have anti-TB drugs which make it possible to improve treatment, to shorten the therapy, and also to switch to outpatient treatment. So we have rapid molecular diagnostic techniques. We have other tools which make it possible to detect TB in suspects, to timely prescribe therapy. So all these opportunities can help us reach that progress faster. And the previous regional plan was completed in 2020, and all the results of the regional plan were presented in the final report for this period 2016-2020, and the report is published on the WHO website. All these facts suggest that we need a document that would offer strategic vision for the region 2020 to 2030, and like what all the countries in the WHO European region and partners need to do so we could reach those ambitious targets. And once again, let me repeat myself. Exactly 1 month ago, on the 14th of September 2022, in Israel, at the 72nd session of the Regional Committee for Europe, the new regional plan was presented. TB action plan for 2020 to 2030, and health ministers of member countries of our European region voted for this document. That was the majority vote, and actually ambitious goals are set. So the TB burden could be decreased by 2030 in line with the global Stop TB strategy. And I'd like to state again, let me repeat myself. So the majority of votes were for this document, and this action plan actually has a strategic vision. So the region should be free of tuberculosis burden by 2030, and the goal is to end the spread of DSTB and DRTB by achieving universal access to prevention, diagnosis, and treatment in all member states of the region, thereby contributing to the TB strategy goal of ending the TB epidemic. So actually this action plan sets very ambitious goals, and you see by 2030 the target is to reduce TB deaths by 90%. So if you compare 2030 to 2020, then as for a reduction in TB incidence, that would be by 80%, and as for improvement of MDR TB treatment, then the reduction should be at 85%. Yes, 2030 has yet to come, and definitely we have our intermediate targets. And so what we are supposed to reach by 2025. So I would like to draw your attention to the following. As for treatment success, MDR-TB treatment improvement, so the rate should be 80%, because we have questions if it is possible, because in 2020 the real rate was 56, and of course it is possible, because Nargiza Parpieva today presented the success rate for the cohort under the clinical trials, and if I remember your percentage correctly, then it was 85%. So if we use no TB drugs, we expect introduction of BPAL and regimens for DRTB resistant to fluoroquinolones. Given the timely early diagnosis, we can shorten that period diagnosis to treatment, and then if we improve detection, then we can reach those targets quite early, and by 2025 this is quite feasible. So this image shows our regional director, Dr. Hans Kluge, who presents this new action plan. That's why the new action plan for the European region tells us what we need to do given the new context for our operations and how we will do that. So we definitely need to ensure high-level commitment at the government level, at the level of country's leadership, and we should promote the policies, so TB should be high on the political agenda, and we can see this excellent experience in your country, in Uzbekistan, which currently results in such perfect results when you decrease the main TB-related rates. And also we need to intensify research and innovations, and in fact this is being done in many countries of the region. So technology is being introduced, health system digitalization is in progress, which in many ways contributes to achievements and reaching the regional targets. And by the way, the structure of the regional plan mimics the structure of the TB strategy. So first we have integrated people-centered care and prevention. This is pillar 1, and actually the red line of the whole plan is that people should be at the center. So we employ people-centered approach. Whatever we are doing should be people-centered. Diagnosis, treatment, prevention, and other components. The second pillar is bold policies and supportive systems. So we need strong support from the country's leadership and also leadership of the programs. They need to help us implement the program and the region on site. Also, we need to ensure that we have strategic information and digital health and other components. The next pillar is what I've mentioned, is intensified research and innovation. I will skip details, but actually this regional plan outlines the priority actions which target both the member countries and the World Health Organization and partner and donor agencies, civil society. So the aim is to consider their inclusion in national strategic plans and documents. This is what is encouraged by WHO, Stop TB Partnership, and other agencies. I would like to highlight the following. National strategic plans are the high-level documents which demonstrate political commitment, so the will of the countries, their willingness to reach those national targets which will further contribute to regional and global rates. And I'd like to note that in your country today there are all relevant strategic documents which you plan to develop and which you've already announced for the coming 5 years, and we can include all the relevant priority actions which are outlined in this regional plan. And colleagues will also add that we have the global strategic documents. One of these documents will be presented by Dr. Andrei Mashinyaga from the Stop TB Partnership. And all documents available so far, all strategic documents, suggest one thing, that we have to strengthen all our measures using innovations, using the available achievements as part of our partnership, so these ambitious goals could be achieved. And if the regional TB plan for the European region, well, it outlines also the epidemiological modeling, these steps which need attention from the countries so they can help us reach the targets by 2030 faster. And I'd like to note here that each component is outlined individually, so we need, if we, for example, focus on prevention only or on treatment, but if used as standalone measures, they will not work because the progress will be slow towards the 2030 targets, and that's why we need to focus on all of them overall, and that's how we can speed up this process towards the targets approved by all health ministers in our WHO European region. And finally, I'd like to say that next year in 2023 in New York, there will be a high-level meeting at the General Assembly session where member states from the whole world will approve new commitments for a specified timeline, and I can only assume that those will be the commitments by 2030 to decrease the TB burden and also to eliminate TB. Let me put it this way, it is more appropriate, and definitely we will welcome all countries there. Leaders from Central Asia countries, from Uzbekistan specifically, at this high-level meeting, so they could contribute to this meeting, so they could stipulate their commitment towards that progress. And finally, I would like to congratulate you once again on your anniversary, and thank you for this opportunity and for your time. Thank you so very much, Oskar, and I guess in this conference hall we have TB doctors representing various generations and different facilities, and I guess they will all share my opinion. Uzbekistan is one of the 53 European region member countries, and for many years we have been working in our country on all the new guidelines. We quickly adapted them to our country's settings, and well, maybe it's not like hand in hand. I guess we worked hand in hand jointly with WHO Regional Office for Europe, so we could complement that important effort. And I would like to assure you that in the future, Uzbekistan will continue to stick to these very tactics, and I hope that we will not fail you. And I guess Uzbekistan will be one of the countries where all these innovations will be promoted. First of all, thank you once again.
And I'd like to give the next floor to the next speaker. This is going to be a video presentation by Sevim Akhmedov, who is in charge of TB HIV prevention monitoring and evaluation team at Global Health Bureau TB Unit, USAID, USA. The presentation is called USAID Global Tuberculosis Accelerator. Well, Sevim is our big friend who for many years was providing direct assistance to control TB in the entire region and in particular in the Republic of Uzbekistan.
Assalamu alaikum. My name is Sevim Akhmedov, and I would like to convey heartfelt greetings from our Division Chief Sherry Vincent, and also express my apologies for not being able to attend the meeting in person. Let me also take the opportunity to congratulate Professor Perpieva and the Uzbek government on your enlightened leadership in the fight against TB. I sincerely congratulate the National TB Program on the 100th anniversary of TB services in Uzbekistan and the 90th anniversary of the Scientific Center of Phthisiology and Pulmonology, and express my sincerest gratitude for your strong partnership with USAID in our efforts to combat TB. Let me start by providing a quick snapshot of countries which we support. USAID's Global TB Program provides direct bilateral assistance to 24 countries, including Uzbekistan, and these are the countries in dark blue on the map. As well as we provide Global Fund technical assistance to additional 32 countries, and these are the countries in light blue on the map. Most of you are probably familiar with this slide. At a global level, if we continue with our current efforts, as reflected in the red dotted line, we will not be able to reach our NTB goals by 2035. What will make the most significant difference is the rapid introduction and scaling up of new tools, new drugs, shorter regimens, a point-of-care diagnostic tool for both TB disease and latent TB infection, and also the development of a vaccine. This is a formidable task for the global TB community. Nevertheless, now is the time to step up the fight against TB, especially given the setback caused by the COVID-19 epidemic. TB and now COVID are the leading infectious disease killers. As we all know, TB transmits through the air, and the drug-resistant forms of the disease exist in every corner of the world. We also estimate that a quarter of the world's population is infected with TB. The UN high-level meeting, however, created new opportunities as the world's governments clearly expressed their commitments to meeting the ambitious targets and leveraging domestic resources. While COVID-19's impact on TB was devastating, it also showed how TB platforms were systematically utilized to respond to the epidemic. And finally, we know that USAID investments are one of the best buys in development, as they contribute not only to the TB response, but help build health systems from community to primary healthcare levels to tertiary care, while curing people and saving lives. The graph this graph is just showing how devastating was the COVID impact on TB. Up to 10 years of progress were lost in several high-burden countries. And although in 2021, we regained some lost ground, clearly we're still below the 2019 levels for TB notifications in USAID-supported countries. The drug-resistant TB remains a public health crisis, as we are detecting only about a quarter of the estimated drug-resistant TB cases, and only about half of those are successfully completing treatment. TB is a disease of poverty, and its impact disproportionately affects the poor countries and the poor people the most. The graph on the right shows data from India that TB prevalence in poor households is 2 times higher than in non-poor households. While the graph on the left shows that out-of-pocket expenses for TB patients are proportionally similar to funding that comes from domestic and donor resources. In other words, about a third of the cost of TB treatment is carried by patients alone. While the UN high-level meeting set very ambitious targets for the first 3 years of implementation, we as a global community are falling short on meeting these targets. As the slide shows, with the drug-resistant TB treatment target having the biggest gap in achievement, followed by the preventive treatment one. The USAID launched its global accelerator to end TB during the 2018 UN high-level meeting with the main aim to align its support and deliver performance-based results towards the global TB targets. This is just an illustrative checklist, it's by no means exhaustive, of the main activities that have been taking place under the accelerator and under its commitment, capacity, and operational requirements. The main underlying tone is that the accelerator focuses on locally generated solutions that tailor the agency's TB diagnosis, treatment, and prevention response to people and communities while combating stigma and discrimination. These 3 pillars epitomize the pivot away from doing business as usual and focusing on locally generated solutions. By providing direct support to governments, civil society, and private sector for service delivery, as well as linking funding to mobilization of domestic resources. Just a quick glance at the achievements under the accelerator so far. Let me again recognize Uzbekistan for being one of the first countries which developed and had a partnership statement with USAID. There are 2 main messages conveyed by the graphs on this slide. One is that our investments do save lives. As you can see, globally, we're estimating over 66 million lives were saved in the 2000 to 2020 time period. The second message is that the steady progress that was achieved over the years was drastically reversed by the COVID epidemic, as we already discussed. Without having to go into the details on the slides, this is the accelerator results framework, which aligns the accelerator reach, cure, prevent, and sustain strategic elements with the UN high-level meeting targets and the WHO anti-TB strategy. Most of you might be familiar with the accelerator's performance-based monitoring and evaluation framework. It is a cornerstone of USAID's efforts to ensure effective accountability of investments in TB at the global, regional, and country levels and accelerate progress to end the TB epidemic. The framework includes 14 corresponding groups of extended indicators that further allow TB stakeholders to analyze data and dig deeper to identify specific programmatic gaps. These standardized, high-quality indicators can serve as a key resource for implementing partners when developing their monitoring and evaluation plans, and to inform USAID's global programming and gaps by technical area. The framework is informed by existing TB strategies such as the Global Plan to Stop TB, the UN High-Level Meeting Political Declaration, the US government's Global TB Strategy, as well as the WHO anti-TB strategy. The PBMEF is a living document that can be continuously updated, harmonized, and adapted to individual country contexts and needs. Currently, we're in the process of updating the PBMEF, and what you see on your screens is the updated list of performance measurements grouped in 4 distinct categories, and which are designed to meet the anticipated new reporting requirements under a pending tuberculosis bill in the United States Congress. This slide explains the rationale, expectations, and intended use of the different indicator groups and the level, for example, national or project, for data generation and reporting. Again, just to reiterate the point and the example that our reporting and surveillance systems are just one example of how TB investments bring about strengthening of the overall health system in our countries, from the community to primary health care to tertiary care levels. And finally, as we're preparing to launch our new USAID TB strategy for the 2023-2030 time period, we did this analysis which shows where countries are in terms of their estimated mortality, presented on the x-axis, and incidence, which is the y-axis. And as you can see, Uzbekistan is clearly in the forefront of having some of the lowest incidence and mortality rates, not only in Central Asia region, but globally across the USAID-supported 24 countries. This is an extraordinary achievement, and you all should be proud and take time to reflect on this special 100-year history of TB prevention and care in Uzbekistan. Let me take again this opportunity to congratulate all of you for your relentless efforts and dedication in the fight against TB, and express again my sincere gratitude to Dr. Perpieva and her enlightened leadership of the TB program in Uzbekistan. Thank you very much. And again, I wish I was there in person, but nevertheless, wishing you a very successful conference. Thank you, Rahmat.
Well, CV Mahmedov sent us his video address. That's why we cannot reply to him, but I will make a phone call to him and inform him that it was very interesting to listen to his presentations, and I will express my gratitude that he gives himself updated on all the TB-related activities in our country. Thank you very much again. The next floor goes to Andrei Moshnyaga, Regional Advisor of the country and community support groups in the Stop TB Partnership in Switzerland. So at Stop TB Partnership, he's going to talk about Stop TB Global Partnership Plan for TB in 2023 through 2030. Thank you very much, Nargiz Nusratu, dear Presidium, dear colleagues, friends. Once again, I'd like to thank you for the opportunity to take part in this conference and the overview of the national program, or review of the national program that is and I'm thankful to my partners, Mavluda and Asker, who are present here, and also my other colleagues who were not able to join, but they will join tomorrow. among them is Luchika. Four years ago, in September 2018, for the first time in history, a high-level meeting was organized at UN General Assembly on tuberculosis control. The time flies. It's been 4 years. And for various reasons mentioned before, because of COVID. Among them, not all of the goals have been achieved, but already this year, through the coordinating role of Stop NTB, in July this year, we developed and published the new global plan to end TB for the period from 2023 to 2030. I would like to thank for immense efforts a team which represents all the regions around the world and different structures and different countries who contributed into this document. And using this opportunity, I would like to thank Uzbekistan, because, well, not only Uzbekistan, but our region of Eastern Europe and Central Asia was represented by Uzbekistan. So I'd like to thank Dr. Yoldashev. He's here for his very active and productive participation in this process, and for defending the interests of our countries and the regions. This new global plan is the plan of investments to eliminate TB as a public health problem by 2030. So this is the year when, as you know, the heads of the state, of all the states, assumed the commitment to achieve SDGs. This is quite an ambitious plan that you can see here on the screen, and the main thing in this plan is about access and coverage. So that motto that no one needs should be left behind is the one that applies to all the countries when we urge them, all countries and partners, so that all of them invest their efforts. This applies to diagnostics, prevention and treatment, and interventions in the plan will globally around the world lead to effect to 80% reduction in those who become ill with tuberculosis, and 90% the reduction in mortality, just like Oscar presented in his regional plan. I would like to emphasize the following in terms of access and coverage. There is a lot of attention is attached to, well, first of all, to ensuring early diagnostics. I'd like to also emphasize that one of the targets, the global targets, is to diagnose at least 95% of pulmonary TB cases using rapid molecular tests, so that in 90% of confirmed cases need to be tested for drug susceptibility before the treatment. In this regard, Uzbekistan, as you know, achieved good results. That's based on the NTB review. 98% of all patients who were diagnosed with tuberculosis were tested using test methods recommended by WHO, and correct me if I'm wrong, Dr. Parpiva. But this by no means means that you have to stop here. As Uzbekistan, just many countries in the world, will follow a global plan. You see the text highlighted in yellow in red font. There's an urge to universally replace sputum microscopy with rapid molecular diagnostics as the initial diagnostic test. No, we're not speaking about completely foregoing sputum microscopy, but what we're saying here is that all people with presumptive TB need to be tested with rapid molecular methods as an initial diagnostic test, and we have a lot of work to do in this regard. What's important? The global plan has a plan of investments. It's been estimated that the total need around the world for this 8-year period to end TB as a public health problem is about $250 billion US, or more than 31 billion per year on average, which is much more than financial objectives that were set in the previous plan from 2018 to 2022. A large part of this money is to be invested for new effective vaccines.
And we really hope so. This seems to be the case based on all the developments. So they could become available for universal use starting 26. At least that's the target. So this increase in funding is needed to make up for lost progress due to COVID-19, to accelerate development and introduction of new TB tools, including, as I said before, the vaccine. And much attention in the plan is given to return on investment. The global plan is an investment in human lives and economic productivity. So investment in TB control is very effective and represents a strong return on investment. Every dollar or so invested will deliver at least $40 US in economic return in benefits by 2050, and low income and lower middle income countries will see an even greater return. As for the financing of TB interventions, we need to mention the cost of inaction. So immense human and economic losses will be incurred if the status quo continues through 2030, and all countries will feel it. And here I discuss 15 ex-Soviet countries, not for political reasons, but for purely TB-related reasons. This slide shows the trends of incident cases and relapse cases in former Soviet Union countries for almost 30 years, 1990 to 2020. And if in 1990 we had some 170,000 cases overall, then you can see here we have Russian Federation and Ukraine. They are highlighted here as the biggest countries, plus 5 Central Asia countries highlighted in green, and the lower curve represents the other 8 former Soviet Union countries. The trends are similar in all countries, and in the sub-region following the initial increase after the peak of disease. In the most so the highest number of reported cases was in 2003 compared to 1990. Then we can see the rates stabilize almost in all countries, and starting 2010 we can see the stable downward trend, and as mentioned today, considerable decrease was reported in incidence and mortality in Uzbekistan. In 2020, 118,000 cases is the total for all, which is quite similar to 1990 rate, and we know that in 2020 we had COVID, and this reduction compared to 2019 doesn't make us happy. And I guess we need to expect that case detection will improve soon, and we expect analysis for the whole world in the new WHO global report, where we will see the comparisons. Hopefully this report will become available 1 week later. WHO Geneva promised to publish its annual report on the 27th of October. And despite the overall favorable epidemiological trends, problems with TB remain in our countries, and you are perfectly aware of one of those. First of all, this is drug-resistant tuberculosis, and this chart shows the share of new and retreatment cases with rifampicin-resistant TB and MDR TB by WHO region. And we can see that the global situation, one on the right. So 3.3% of new cases were reported, MDR TB cases, and some 18% retreatment cases. Then in European region, which also includes Central Asia and Uzbekistan. So this level is way higher, 17% for new cases and 52% for previously treated cases. And this chart, again, as of 2019, the latest data analyzed by WHO. So the dark blue shows the former Soviet Union countries, the green lines are Central Asia countries, and the red is Uzbekistan, although the situation in Uzbekistan seems better compared to other countries, but the problem still remains, and we should not relax here. And one of the priorities of the new global TB plan, namely Chapter 6, suggests that ending TB through universal health coverage, pandemic preparedness and response, and socioeconomic actions should take place. One of the priority actions, an important one, is that we need to expand access to TB services through UHC initiatives. UHC is short for universal health coverage. So it suggests that all people and all communities will receive the health services they need without suffering financial hardship. So actually UHC is one of the objectives of Sustainable Development Goals. And well, we can show you what UHC is. In fact, you can represent it as a cube where we have key dimensions: coverage, financial protection, and availability of services. So who is covered, what services are included, and how much is covered by the state. So this green cube inside the bigger one represents what we, by we I mean the region and the country specifically, so is what is going on, and we have the capacity to improve access and coverage by providing services for vulnerable groups. And also, if we extend it to those groups, as I said, if we eliminate out-of-pocket payments and if we add new services. To what extent it is relevant for TB control? Well, it is very relevant because I guess for Uzbekistan specifically, if we take into account the solid reforms in progress in the country, I mean introduction of state health insurance. So the principles of the UHC need to translate into specific actions in countries' health systems, which is not quite easy. An important point here is that if you only increase the financing for TB services, it will not be enough. There also should be appropriate allocation and payment mechanisms that would secure delivery of TB services to all people in need. So, in short, we can say that, okay, if not TB, then what needs to be included in the benefits packages? So, what should be included? Well, given the TB's individual health and public health dimensions, there are also well-known externalities, so that it is very infectious. It should be treated as a high priority, and also we, with the Global Partnership, advocate that actually all dimensions of the TB coverage cube must be filled as close to 100% as possible. As for TB prevention, diagnosis, and treatment interventions, they should be integrated in the packages of essential health services provided under prepaid health finance and coverage systems. So, mandatory health insurance, or as is the case in Uzbekistan, state health insurance, is one of the good examples of prepaid health financing systems. So, thus, providing the full range of TB services for all, plus absence of financial hardship for people and households affected by TB, equals implementation of the universal health coverage principle in healthcare. And maybe I will skip the last slides due to time limits, and I want to highlight the last but not least. So I would like to highlight the following. So universal health coverage in TB implies proper focus on gender ethics, equity, and human rights. And I guess a lot has been done in the country, in Uzbekistan, and a lot will be done soon, given the implementation of the new government program and with the support from the new Global Fund project, which will need to be developed, and also specifically with regards to stigma and discrimination and their implications for the TB response and access to TB services. More work is needed. Thank you so very much. Thank you for attention. Stay healthy. Thank you very much, Andrei. And I keep saying that here we are one big family of WHO, European region, Stop TB partnership, and Andrei is our long-standing friend. Yeah, thanks to technical support from USAID, so Viarel Sultan, Andrei Mashняga, they helped us back then when we had to quickly transition to the new financing modality to become the primary recipient of the Global Fund. And thank you so very much for such a well-established operation now. And since for technical reasons we do not have the presentation from the Global Fund, we would like to give the floor to Bernd Thomas Nyangwa. So, tuberculosis global perspectives. He is MSF medical director in Netherlands. So please. Bernd, the floor is yours.
For the invitation and the introduction, and greetings to you all. I'm going to attempt to convince you on this concept that shorter is better. A number of colleagues have already presented and shared the information around the different components to try and improve the TB epidemic. They've talked about policy changes. They've talked about diagnosis. They've talked about collaboration and so on. My focus is going to be on treatment. And maybe you'd ask, shorter is better for whom? I would say, in the next couple of slides, I would say shorter is better for the patient, shorter is better for the community, shorter is better for the health system, shorter is better for us as healthcare workers. So hopefully at the end of this, I'll convince you indeed that shorter treatment is better treatment. But if I don't convince you with that, then I'll try to present this in a very short presentation, and maybe you'll be convinced that somebody presenting for a short time is actually good for you. So in the next couple of slides, I'll talk about tuberculosis preventive treatment. I'll talk about drug-susceptible TB treatment for adults, drug-susceptible TB treatment for children, drug-resistant TB treatment, quinolone-susceptible and quinolone-resistant treatments. And the last slide is just to look ahead on the drugs pipeline for the treatment of tuberculosis. So as some of you would already know, WHO has been producing these consolidated guidelines on treatment, and there are different volumes, you'd say that, but most of it, with the approach that WHO is currently taking, is heavily dependent on research that has been conducted to show the benefits of particular interventions. Now, the recent WHO recommendations on tuberculosis preventive treatment gave a couple of options, and I just took a snapshot of one of the tables in there. So they gave a couple of options. They gave isoniazid for 6 months, or isoniazid and rifampicin for 3 months, and that could be given weekly. They gave an option of isoniazid and rifampicin for 3 months as well, but that would need to be given daily. Rifampicin for 4 months, that would need to be given daily. And quite a regimen that is, in a sense, pushing the boundary is giving isoniazid and rifampicin for 1 month to be given daily. Now, in this recommendation, WHO, of course, gave all of these options because the research that was there did not necessarily suggest that one is more important than the other. But what this provides as an option or an opportunity is that you could, if you decide as a program to be able to provide tuberculosis preventive treatment, you could provide treatment that lasts just for a month, keeping in mind most of it has been around 6 months or 9 months, but you could give it for 1 month, or you could give it for 3 months, whereby the patient is taking the treatment only once weekly, which is 12 doses in total. So I would say for preventive of TB treat or preventive of TB disease, by prevention, by giving the treatment, you could definitely do it shorter than is currently done now. I'll quickly move to the treatment of drug-susceptible TB treatment in adults. Here, I know that most of us provide for drug-susceptible TB, we provide a 6 months treatment. But I'd like to highlight some of the research by Susan Doman and colleagues looking at different regimens and seeing whether they are non-inferior to the standard of care. So giving 4 months treatment regimens for drug-susceptible TB to try and see if the patients do as well. And their publication, which came out last year, which then and WHO used that data to make the recommendation to consider a 4-month regimen of isoniazid, rifampicin, moxifloxacin, and pyrazinamide for treatment of drug-susceptible TB. I have to highlight, though, that we know that this was a strongly a proof of concept, because we know that rifampicin is still very expensive and a bit difficult to access, as well as that the pill burden is quite high. But at least I think what this study did show is that indeed you could treat drug-susceptible TB in less than 6 months, in this case for 4 months, and WHO has provided that as an option. If we go to drug-susceptible TB treatment for children, again, we've seen research by Anna Tokova and colleagues that was published this year, actually, looking at shorter treatment for non-severe tuberculosis in African and Indian children. Some of this and previous research as well also contributed to WHO making a recommendation that for children and adolescents with non-severe TB, they could be treated with a regimen that is 4 months, which includes isoniazid, rifampicin, and pyrazinamide plus or minus ethambutol for 2 months, and then have a continuation phase of 2 months of isoniazid and rifampicin. Now, this is interesting because in this regimen is the same regimen that we use for treating drug-susceptible TB for children and adults. However, what they were able to show, which I think most of us know having worked in tuberculosis, is that when we give the long treatment, it's not necessarily that everybody needs the long treatment. It's because some patients who might have severe disease or might, for other reasons, not be able to be fully cured in a shorter duration. So we give the long treatment to all patients. But in this case, which was very helpful in the studies that were done, and also the recommendation from WHO, is to say you can actually identify a particular group of children who could benefit from a 4-month treatment course. We've talked about drug-resistant TB a little bit earlier, and I know my colleagues will talk about it more in detail tomorrow as well. But as you would also know, in May, the World Health Organization produced this rapid communication around the treatment of drug-resistant TB. And one part of that was looking at the treatment of quinolone-susceptible drug-resistant TB. And this comes from, as I mentioned earlier, from a clinical trial, a multicentric clinical trial, of which Uzbekistan led the way in bringing together that trial. And the results have shown that use of a 6-month regimen of bedaquiline, pritomanid, linezolid, and moxifloxacin can do not only as good as, but better than longer treatment that we've been given. WHO did review data not only from 18 to 24 months treatment, but they also reviewed 9 months treatment and tried to compare and see that. And this rapid communication was indicating that level of preference, and we look forward to the final guidelines that hopefully should come out either at the end of this year or beginning of next year for it. But the graph in the middle is just showing the clinical trial results, which showed the different regimens that we trialed in that, which was bedaquiline, pritomanid, linezolid, and moxifloxacin, which we've already talked about having the 89% success rate. We also looked at bedaquiline, pritomanid, linezolid, and clofazimine, which also did much better than the standard of care, but not as well as the BPAM regimen. and also the bedaquiline predominantly linezolid, which again did much better than the standard of care, but not necessarily not as better as the one with moxifloxacin. So again, in this situation, you could give a 6-month regimen of bedaquiline predominantly linezolid and moxifloxacin to treat quinolone-susceptible rifampicin-resistant tuberculosis. Francesca Conradi and colleagues with the support of the TB Alliance also did a publication which was came out earlier in the year, but had been information shared around looking at quinolone-resistant drug, rifampicin-resistant TB. And this again was integrated in the WHO analysis of data, and that led to the recommendation that 6 months regimen of bedaquiline, predominant, and linezolid should be given for patients who have quinolone-resistant tuberculosis. And I know both of these, given that we've moved from 24 months, 18 months, in some situations trying 9 months, and seeing 6 months might be feel like, okay, is this actually real? But for sure, we have the research data. We look forward for countries and programs moving forward to implement this and follow the results, and to be able to continue to share how shorter is actually better, even in these resistant patients. Finally, just looking ahead, I think tuberculosis is one of the illnesses that we know in terms of new treatments. This has not been as fast as we could have expected, but we've seen a significant progress in the last number of years. And that progress continues to be encouraging, because we know that when you use antibiotics, sooner or later they become resistant. We need to try our best to avoid that happening, but we know that that's a reality with antibiotics, and therefore having new drugs and so on being developed is it's a very positive thing. And in addition to that, we've talked about the 6 months treatment for drug-resistant TB, potentially 4 months treatment for drug-susceptible TB, potentially 1 month treatment for prevention of TB disease development. And maybe we shouldn't stop there, because if we really think shorter is better, why don't we go even further? So I know that other colleagues are working on some of those aspects. This slide is just a summary of that is produced by the Working Group on New TB Drugs, and that looks at the different drugs that are in the development, and in the phase 3 to the right of this slide, they also include regimens that are in development. I think what is quite encouraging when I look at this slide is indeed the identification of new molecules. So as you know, quinolone was the new molecule that we've seen as bedaquiline, which had not been used for treatment of TB, and it's changed a lot of what we see. But there are new molecules in that category that are expected to be being researched, that are expected to be better. Of course, there are other molecules that are being here. They're just put with some of the stars, and these are new drug classes that we're not using at the moment, which would hope using them can actually not only overcome resistance, but potentially make treatment better and shorter. I think I'll stop here. I hope I have started trying to convince you about that shorter is better. And again, if it's not about the actual treatment regimens, then then hopefully my presentation has been short enough to convince you that shorter is better. Thank you.
Thank you so much, Bernd. You're always convincing. Some time ago, you convinced us to start together with you and Professor Teleshaykhov to start our research 6-month TB practical, where we tried different treatment regimens, and now we have the first few results, and we're very thankful to you, and we hope that we will continue this work together. And it's a great joy for me to introduce you to our favorite Teresa. I might not pronounce your patronymic correctly, so I'm introducing Teresa to you. This is in charge of the Global TB program from WHO. And Teresa, we have postponed your presentation a little bit, but it's not because we didn't respect you. I didn't want to hear it in the first line, but because you have a difference in time. So we thought this would be more convenient. I'm so happy to see you, and I would like to give you the floor. And we are so happy that you're taking part, at least online, in this conference. We did hope to see you in person, but at this anniversary conference. Thank you very much, and you have the floor. Thank you very much, dear Nargiz Nusratna. I hope you can hear me. I unfortunately cannot be present, but it's a great honor, dear colleagues. There's a global community is represented here. And we've been working successfully. I'm sorry, there's no sound input in the interpreter's booth. This conference is taking place at this time when our countries are taking major effort to combat TB. As you may know, and we hope that we will be able to. We're hoping that we'll prevent a situation when TB will take the position of the leader. Unfortunately, we're observing an increase in incidents around the world. Major efforts were made to reduce incidents, but it's not happening as fast as we wanted. And right now, we're being thrown back. The trends are very alarming, but everything is in our hands. And how effectively and quickly we will be able to stop these trends and, again, ensure progress in the future depends on us. It is inadmissible that more than 4,000 people daily died from TB, which is fully preventable and curable in most cases. And right now, you heard our dear colleagues And now we have more opportunities with new treatment regimens. We can get the new vaccines as well. And thanks to our joint efforts and the community in Uzbekistan, we were able to preserve more than 70 million, save more than 70 million lives around the world. But we need to do more. COVID-19, well, it ruined many of our plans, and still the health services have not yet gotten back to their regular norms, and we are not even back to 2019 level when it comes to coverage with diagnostics and treatment of TB patients. In addition to that, we see other types of crisis, including economic ones. There are significant flows of migrants, and we know very well that unfortunately TB patients are among the most vulnerable populations. That's why we need to jointly attract attention to this problem. Elimination of TB requires not only the TB community's input, but all the socioeconomic crisis of which hit many populations that also influences hardly the TB patient social support, the assistance in different kinds. It needs to become an integral part of multi-sectoral measures to control TB. We are waiting for involvement of new, unconventional actors in TB control, such as young people, students, activists of different kinds. Civil society also plays a critical role. Dear colleagues, as you know very well, in 2023 we will have the second high-level meeting on TB control of the UN General Assembly. This is the highest level of a forum that helps to draw the attention of heads of states to this problem and the highest level decision makers to TB control. And we need to make use of this opportunity just like the first time. We need to make full use of it. And you will probably hear this for the first time from me, because I just received information from the New York office that facilitators for this high-level meeting on TB were appointed, facilitators, and these include esteemed Mr. Ibrahimov, the outstanding representative of Uzbekistan in UN. The second co-facilitator is the representative of Poland. This, of course, is a great honor and recognition of your services as well, and achievements as well, that your country is going to be participating in preparing the high-level meeting of the UN on TB, and that helps us to work more closely and help us with political declarations and reflect all our needs and additional investments into assisting in TB control, science innovations, and ensuring access as soon as possible to them. On this positive note, I would like to finish my short speech. I'm sorry that I had to be added to your agenda, but I didn't want to miss this opportunity. I was in Uzbekistan together with the regional director, Hans Kluge, and he invited me for the trip, and for me it was a great honor, and I remember the detailed discussions we had with Dr. Parpiva, with other colleagues. I'm impressed by your achievements, and I hope that we will continue working in close partnership with you. It's a great honor, and I really bow down to all the TB doctors because you're contributing not only to achievements in not only of domestic healthcare health system, but also global health system. And I wish you success and hoping to continue our collaboration. Dear Teresa Chermendovna, allow me to try to convey my emotions from the news that we've just heard from you. Thank you so much for the very pleasant and positive news. I would like to thank you because that TB control, that control efforts that are taken in our region, including Uzbekistan, this has been done under the guidance of the World Health Organization, and there's the same approaches and the same high-quality diagnostics and high-quality drugs, and these help with our success. But the fact that you were able to highly appreciate the contribution of TB doctors in Uzbekistan and our work with and our national partners in Uzbekistan. I know that you're sincerely
I know that actually you do not select countries like priority countries, and you equally distribute your attention. And I can recall our discussions we had in February 2021 when you visited our country, and I can remember those discussions, and I would like to assure you again, Uzbekistan will try to meet all your expectations, all the hopes, and thank you once again. Yeah, I was disappointed a little bit when I heard that you and Hans Kluge would not be able to come, but as for this Zoom session and your online message, which you managed to organize quickly, well, thank you so very much for that. We would like to assure you that we would try to invest every effort to deploy all our capacities so we could address all the issues before us, acting as one team, all countries combating TB. Thank you once again. And please come and visit us. Teresa, I promise I will. Thank you. See you. Well, I need to announce that now it's time for discussions. I hope you will have questions to members of the panel, to our partners, to representatives of the National Tuberculosis Program. Please ask your questions and we will try to answer them. And also I'd like to say that we have some 15 minutes for that, so you are welcome.
Может быть, у наших председательствующих есть какие-то комментарии или вопросы, что-то вы хотели бы добавить?
Maybe you have comments, maybe you would like to take this opportunity. Our international partners or specialists of the service, maybe you have some questions. Yes, please. I would like to introduce to you Nicholas Nasidze, Senior Advisor to the National TB Program, USAID STAR Project. Nicholas, please. Microphone.
Большое спасибо.
Thank you very much, Dr. Nargiza. I would like to thank all the presenters and also congratulations on the news. We've just heard about being co-chairs at that meeting, and yeah, this again highlights all the country's achievements. So once again, congratulations on this news. And my question is, we all could see that when we had that first high-level meeting in New York, then STOP-TB calculated the targets for countries. So they could cover the missing number of patients, those under-detected. So they had to be covered with the preventive therapies. And that was essential for countries, so it could be easier for them to be guided by those rates. And my question is, do you plan to do the same after the second high-level meeting? And to what extent these targets, when you will be calculating them, to what extent you will seek advice from countries so they could be relevant to their settings? Thank you. Dear Nicholas, thank you for your question. So I guess if Dr. Teresa is still with us, I guess she could respond. Well, Teresa, the floor is yours. Yes, thank you very much for your very appropriate question. It was right to the point. So as for this high-level meeting, yes, the last political declaration set the global targets and the indicators to cover with treatment at least 40 million people and to cover with preventive treatment at least 30 million people. And also the financial targets were identified at least 12.5 billion USD annually was required to cover all the needs, but those were just the global targets, and immediately questions were asked like what should be the contribution by countries, and selected indicators for countries were not identified. And at that point, definitely STOP-TB partnership, we need to admit they acted quite proactively. They suggested a model. Well, actually, quite a few of those, but again, it was an option for countries. If countries decided that that would be appropriate for them, they could use those rates. And that was not binding, that was just a recommendation. And as for us, WHO, some countries approached us, and the agreement was the following. If a country is interested in setting its own country-specific rates in line with the global rates, then we jointly with the colleagues from the European office and the global office, engaging experts from the same STOP-TB partnership, we would reach consensus and we will outline those indicators, because in addition to formulas, we also had to take into account specific characteristics. Again, if the new document has such rates coordinated with the countries, and we hope that we will have the global rates, then we are willing to discuss with the countries on a case-by-case basis what is recommended for them. That's the current position, but in no way we will dictate top-down any rates if they are not coordinated with the countries, and if we fail to reach understanding with them. So also we will take into account like what we managed to reach based on the previous declaration. what we need to take into account in the new declaration. And definitely those numbers are important for advocacy, for raising funds, but also, I guess, percentage-wise, the rates will be important for countries. So as for 40 million people to be covered, like what it means percentage-wise with regards to access to treatment for TB patients, if relevant percentages are identified globally, then I guess that will help countries. And currently, we welcome your vision, your suggestions, which might help us and the countries make the most appropriate decision. That it is high time for these discussions. Thank you very much, Teresa Chermenovna. I'm pleased to see that you are still with us, because the news you've just broken, well, Nicholas became very interested and as well as other participants, but I guess many of us have yet to absorb this news. But we are so happy that our representative in the UN will co-chair, because in fact you cannot overestimate the importance of this upcoming global meeting, because the motto and TB, where we have to eliminate TB globally and address, the country leaders need to address that issue. They need to prioritize it from among many relevant issues. And I believe that the NTP team should mobilize even and work even harder. Yes, now we are summing up our previous achievements, what happened in the last 100 years in the country, but it doesn't mean that there is room for complacency. A lot of challenges are ahead of us, and you've correctly mentioned that COVID-induced TB, which we see in our patients as well, in fact, this is with us, and the immune deficiency status and the comorbidities. So COVID results in the fact that people with even latent diseases now have those diseases manifested, like diabetes mellitus or diseases related to coagulation. So in fact, there are such effects, and I guess all those present here and the bigger team of TB doctors in Uzbekistan perfectly understands that we cannot relax now. It's too early for that, and we have new knowledge and new equipment and new opportunities, as mentioned in the presentation by our distinguished colleague Baron Thomas from British Office of MSF. Well, definitely we need to use new approaches to treat our patients as soon as possible, because the objective before us is to see that our patients get cured, and we need to also analyze deeper latent TB infection. Maybe you have questions. Yes, please. But please introduce yourself. If this mic is not working, you can use ours. Our representative from Kyrgyzstan. So yes, please, come here and use this mic. Good afternoon, dear colleagues. Dear Nargiza Nusratovna, on behalf of Kyrgyz Republic and me personally, I would like to congratulate you on such an excellent event on your anniversary. And I guess we will have some time for discussion later, but my question now is to representative of MSF, Baron Thomas Nyangwa. So do you believe that soon we will announce that like we can treat TB within 1 month or even within a shorter period, and that treatment will be better? Treatment, yes, it's about treatment.
For the question. I think what I was trying to highlight is perhaps to encourage us to continue hoping better or planning and researching better for our patients. The 1 month treatment that I referred to was around the research that was shown and also recommended in the drugs-able TB preventive treatment for that can be provided in 1 month. So the combination that has isoniazid and rifampicin given daily for a month is a regimen that needs to be considered. However, I know that there are a lot of other research activities going on, trying to look at much shorter treatments, and of course that needs to be encouraged. And again, of course, having given the research, clinical trial research capacity that has been developed in the country, participating in those multi-country research initiatives would be encouraged. So I'm much more hopeful that that would be the case, but of course we need to do the research. We need to try to get there with evidence. Thank you.
Thank you. Спасибо большое. Я вижу Манс.
Yes, I can see Mansa has raised his hand. He was the coordinator MSF Karagal Pakistan. Now he represents KNCV. Okay. Thank you very much.
My former boss and still my boss. So as the TB practical has already shown effective results right now, so and MSF is planning to do further operational research with those regimens. So I just wanted to ask why MSF decided to do operational research if already we have a rapid communication from the WHO recommending a programmatic implementation. So why MSF did not go ahead with the scale up to programmatic implementation? That's the first question. And the second question is about the future of TB practical. So because we see that there are already drugs in the pipeline. So and what are the plans for the future? Is the TB practical going to continue with further clinical trials to find more effective regimens? Because even though with the 6 months, we still have some side effects with the drugs also in it. So is there any further plans to go ahead with further shorter regimen and less toxic drugs? Thank you.
Thank you, Mansa, for your questions. As you know quite well, as MSF, we work in collaboration with ministries of health, and we work and discuss how best to ensure there's access to these regimens. We are sure and convinced that the data that was obtained from the TB practical trial is strong enough data to be able to use the regimens. And as you rightly mentioned, the WHO, having reviewed the data in detail, made the rapid communication to communicate as such. However, we also know that changing national guidelines, getting Ministry of Health's precursors take time. That is the time that we probably, or let's say, patients and communities affected with drug-resistant TB do not have. And therefore, sometimes operational research is primarily an approach to try and access these treatments. But also, you just talked about side effects. I know in discussions around the dosing of linezolid and so on, there are still outstanding questions that are much more of a detail, and these could be answered through additional research. But I'm also aware that there are countries that are considering and have already started moving to provide that treatment at a programmatic level, and I'm quite sure that when WHO do produce the full guidance and the clinical handbooks, and then more countries will take up this treatment. So, in short, I don't necessarily see operational research as absolutely needed to provide additional data, but it could provide access to these treatments early while collecting additional information on these regimens. The other question maybe is a bit more, requires a bit more discussion. We had clear intentions and agreement again with our collaborators, as you know quite well. TB Practical was not just an MSF only treatment and clinical trial. This is a collaboration of over 17 institutions, hundreds of clinicians and specialists, pharmacists, nurses, and so on. And these discussions on where to go from here could continue, but at the moment we do feel that the objectives and aims of TB Practical were achieved, and therefore that's where that aspect of the project ends. But of course there's more discussions to be had on what more can this capacity that has been developed contribute to future TB treatments. Thanks.
Thank you.
Thank you very much, Mansa and Dr. Byrne. Do you have any further questions? There was a question that was sent in writing. I didn't quite understand it. Dr. M. Tursunova, or Tursunov, is asking me in Uzbek that in 2021 and 2022 there's a rise in labor migration because during COVID there was no way to travel. Now in post-COVID time there's way to travel. If a patient is diagnosed with a disease, then how do we organize their treatment and how do we monitor the case? I should say that in reality, well, in the past there was a larger flow of labor migrants from our country to other countries. But at the moment, we're observing an influx of labor migrants into our country. So our country has been addressing this question for quite a while. When migrants who were away for 3 months and more from the country, they are advised to have an X-ray examination, fluorographic examination in their local clinics and for TB and other infections as well. But I would like to say that TB drugs provided by Global Fund are provided free of charge to everyone in our country, including non-residents who live and work in Uzbekistan. In addition to that, with many countries to implement Resolution 4191, we have adopted an interagency order with between Ministry of Health, Ministry of Interior, Ministry for Labor Protection, and so on and so forth. This document was signed, and it sets forth the legal grounds, the regulatory grounds for testing and treatment of all of those returning labor migrants. In addition to that, this administrative order was not only intersectoral, but it was an inter-country order. So it touched upon TB control, and we've been addressing these issues on the Central Asian regional level, and there's a lot of work being done in this regard. For example, if our national lives and works in another country and is diagnosed with this process, then this disease is treated, in this case TB is treated in that country, and when necessary this patient is transferred to us. The same applies to the other countries. And when our nationals come to the labor migrants come to the Russian Federation, they're examined for TB or screened for TB. And if they are found to have TB upon entry to the country, then they're returned to their country of residence. If they develop TB or they become ill with TB sometime later after arriving to that country, then that country will provide the treatment. The country of sojourn will provide the country. And we exchange information as well between countries. So information about these detected patients is provided to us as well. So we keep records jointly. So upon completion of treatment there, these people can return to our country and be monitored here. So these were also reflected in our legal and regulatory documents and in some other ways as well. I hope that I answered this question. If not, then come up to me later. We'll have a discussion about this. Any further questions? Well, if there are no further questions, I do see, I'm mindful of the time. The delegates of our conference ought to have the vouchers which show where you're expected for lunch. On your vouchers, please take a look at the name of the hall where you will be served lunch. So the break will last until 2:20 p.m. In 2:20 p.m. we will start another plenary session. It is an interesting initiative of WHO office, and this is going to be an overview of initiatives. And there are going to be 3 more sessions, and we will announce them later. Thank you. Bon appetit.
First of all, I'd like to say that in this room, we will have the plenary session, overview of WHO Regional Office for Europe's initiatives. At the same time, in Samarkand, we will have issues of diagnosis and treatment of extrapulmonary tuberculosis in the framework of the multidisciplinary approach to practical medicine. Then in Bukhara, we have adherence and psychosocial support in patients with respiratory pathology. And Holhiva, COVID-19 challenges for the healthcare system. They have started already. And my co-moderators are Askaria Dilbaev, Mikhail Volig, who is a consultant for WHO Regional Office for Europe, and also we have with us Nicholas Nasidze, our advisor, is part of the USAID STAR project. So the first, will it be online or do we have a record?
Ага, хорошо. У нас...
So as I said before, for 2 weeks we've had NCP review. Actually, we started even before, first online and then offline. And based on the preliminary findings of the NCP review, actually the plan was to have Aktay Gazalov as a presenter. Unfortunately, he couldn't come to the country, and we will ask Tom Hyatt, please.
Ladies and gentlemen, thank you very much for the opportunity to present the preliminary results of our National TB Program Review. As Dr. Parpiva mentioned, Dr. Oktay Gosalev was meant to lead this mission but was unable to attend, so I'm leading in his absence. So allow me to give some overview of what we've seen. So first off, some details on the review. As Dr. Parpiva mentioned, we had a online portion first, virtual, and then the last week we had a in-person part. So part of our review team only participated online, and part of the review team came physically here to Uzbekistan. We had 16 international consultants who were assisting with this, both in person and online. And we visited 4 regions. This is just an image of some of us, not the entire team, but some of us to get an idea of getting started here. In the regions we visited, of course, Tashkent city and also the Tashkent region. Sirdarya region and Bukhara region was one team visited, and another team, second team, went to the Republic of Karakalpakstan. Before I start on the findings here, I want to highlight a few epidemiological findings. I know we've covered some elements of epidemiology already in this conference, so I won't make it comprehensive, but I want to highlight a few especially remarkable achievements for Uzbekistan in the region. This first graph you'll see here shows new and relapsed cases tested using WHO recommended rapid diagnostics as the initial diagnostic test. You'll see the bars. These are total new and relapsed cases and those who are diagnosed with WHO recommended diagnostic tests. Drawing your attention to the red line, you can see that gradually this has increased since 2016 all the way up to 98% in 2021, which is a remarkable achievement and something we at WHO are promoting globally. And really, it's excellent to see Uzbekistan leading the way for other countries in bringing this huge achievement forward. The next one I would like to mention here, you can see in this graph of notifications of bacteriologically confirmed and clinically diagnosed TB. among new and relapsed pulmonary cases. And again, if I draw attention to this red line, this is the proportion or percentage of cases, patients who were bacteriologically confirmed. And you can see this continuously rising since 2015, already up to 71.5%, which again is really an excellent achievement, both epidemiologically, because we understand better the epidemic, but most importantly for individual TB patients, because we have that confirmation that what the disease they're struggling with is indeed tuberculosis. Next, let me highlight just some figures here. This is treatment success we're seeing, and for drug-sensitive TB, globally, we are at an average of 86%. Now, in the European region, our target for treatment success of drug-sensitive TB was 85%. Now, globally, the target is 90%, whereas globally, we're at 86%. We're a bit lower in the European region at 75%. But in Uzbekistan, we're seeing 91%, which is higher than the average in the region, higher than the average globally, and already achieving the global target of 90%. This is really excellent to see this kind of performance. Looking at drug-resistant TB, we see globally 59% is the average. This is slightly lower in European region, 56%. And here in Uzbekistan, we're already at 70%, which is really wonderful to see for drug-resistant TB. And even more so, I'd like to show what's the preliminary results. Again, these are preliminary. For the MSTR regimen, the short treatment all-oral regimen, initial findings already is that treatment success in the European region, much better, 86%. We're seeing using this new regimen. But in Uzbekistan, we're seeing that all the way up to 92% with preliminary results, which is just commensurate with DSTV, which really, really an amazing and excellent achievement. Very well deserved. Excellent work. I'll show you just a few images of our work in the field so you get an idea of what we've been doing the last couple weeks. This is in Nukus, the team there gowning up for part of their review mission. So let me talk about some system reforms level findings and achievements that we've seen here as well. Number one, in Uzbekistan, TB is on top of the political agenda. So there's the state program on TB and lung health for 2022 to 2026, which is being developed based on main elements from the National Strategic Plan 2021 to 2025. Clearly, it is a top priority for the Ministry of Health and also for the broader administration of the government. We're also seeing that the capacities and performance of the NTP have substantially increased. It's strengthened its function as that key central unit, and now it enables them to effectively lead and steer the national TB response. This building up has been, I think, gradual and continuous, and really we've seen the strength of the program over years and years of investment and attention that has come through here. As well, we're seeing health financing reform. This is bigger than just tuberculosis in the Ministry of Health, but it's really important. It's being implemented with the introduction of the state health insurance. So with this state health insurance rollout, it's already in Sirdarya as a pilot region. And starting in 2023, we'll roll out further. It will facilitate the realization of universal health coverage principles and bringing substantial benefits in terms of access to and quality of healthcare, including TB services. This is really, really a great finding and a great element of progress. Here's just an image of discussing with a TB patient in Sirdarya. Very important to understand the perspectives of the final recipients of our care and services and understand what their experiences are. A few high-level recommendations at the system reform level that we'd like to mention here. Number one is that the Ministry of Health and the State Health Insurance Fund to continue developing the legislative and regulatory frameworks for keeping the pace of the planned rollout of health insurance to other regions, which should fully integrate TB services at all levels of care. Second recommendation I'd like to mention here is that essential TB services should be explicitly included in the state guaranteed package of services, the basic benefits package, covered by the health insurance system. And the Ministry of Health and State Health Insurance Fund, with technical support by WHO and other partners, to develop specific provider payment mechanisms as well. So along with that package that I mentioned. So the next one I'd like to mention is the secure and dedicated funding stream for the National TB Program as a central coordinating body. Already, this will ensure appropriate coverage with essential TB interventions to support UHC and expand the scope of the National TB Program, including TB prevention, implementation of new tools, and patient support. So until now, the great progress and the strength of the NTP has been pulled through different financing, tangential financing streams, and with a dedicated financial stream that's not just linked to patient load, which is what's been happening, will provide that support that's required. Here's another image here from Nukus that I'd like to show you here of looking at registers, digging into the details so we can really understand how things are going. At the technical level, I'd like to mention a few findings as well. The first one is we have modern real-time web-based electronic data collection system. This is called DHIS2, stands for District Health Information System, developed by the University of Oslo decades ago, and it's a very mature system used worldwide in different countries to different extents. It's open source, it's free, so a very good system that's already in line with WHO recommendations and has been adapted to the national context here in Uzbekistan, accepted by the Ministry of Health and approved for a pilot project. So that's really great achievement. Also, as I kind of alluded before with mentioning the MSTR, we have full transition to WHO's recommended fully oral treatment of TB and drug-resistant TB. And this, we're really seeing the results already come through. So that's an excellent achievement as well. There's been introductions of innovations in research, operational research, and clinical trials. We've seen some of them out here in the foyer. The Practical trial, MSTR I mentioned, BPAL Plus, and others on the way. So this kind of work into research both benefits Uzbekistan, but also the broader global community as we draw from these results. This next one I want to mention is, I think is especially remarkable because it's unique to Central Asia. Is here in Uzbekistan we have a procurement of all medicines and TB, drug-resistant TB, through an international procurement mechanism, procuring drugs from the Stop TB Partnership's Global Drug Facility. And 100% of first-line drugs and an increasing amount of second-line drugs are procured with state funding. This is unique to Central Asia. Uzbekistan is really leading the way in this regard, and really we're hoping at WHO that other countries follow suit and take advantage of the learnings that's already taken place here. This is another image speaking of the Practical trial. We're examining this here with our part of our team, looking at the excellent work being done there and in this research project. A few technical recommendations I'd like to mention here. Of course, this is not comprehensive. This isn't all the technical recommendations which will come through in the report, but these are ones we thought would be most useful to highlight at this stage, at this preliminary stage. So number one is Uzbekistan has a high potential for systematic screening for TB disease among at-risk populations. So political will is there, policies are in place, available infrastructure is there, adequate human resources on the ground are there. So that structure is really really well developed and well in place. Secondly, I'll mention that there's the web-based electronic data collection system that I already mentioned is essential to ensure adequate recording and reporting for TB. So can we take that pilot project, make it work, and roll it out nationwide? This is very much a need well seen across the country for this electronic recording and reporting system. Next recommendation, to introduce a comprehensive laboratory information management system. LIMS is what it's called internationally, for the laboratory network to manage timely and effective information exchange. So already there's some good work in electronic systems in the laboratory network. This is an upgrade to a fully comprehensive laboratory information management system. Next, I'd like to mention around TB screening, to analyze the results and reprioritize target populations for systematic screening for TB disease in accordance with the latest WHO policy guidelines. Again, this screening mechanism is in place. The data is rich and coming in. Analyzing that data, honing our efforts will increase the yield and help us reach more and more people who need to be screened and diagnosed. Next recommendation, to expand access for all patients, drug-susceptible TB patients, drug-resistant TB patients, and children, to shorter, fully oral treatment regimens under operational research and routine programmatic conditions where appropriate. Again, we see the strength and the amazing results from these fully oral treatment regimens. Next, I'd like to mention the recommendation to ensure universal access to all TB preventive treatment options recommended for use by the national TPT guidelines. This includes shorter rifamycin-based regimens, 3HP, 1HP, and 3HR as well. Ensuring access to TB prevention is integral. And of course, a partnership with the screening that's already so strongly in place. So with strong screening, strong prevention, we're going to make a big difference, and that will really be the next chapter, the next phase for seeing the reduction in TB incidence in Uzbekistan. Thank you very much. Those are the recommendations I mentioned here. A few acknowledgements. Thank you to the government of the Republic of Uzbekistan, Ministry of Health, of course, NTP and regional TB centers, to the patients that kindly gave us of their time and experiences for us to understand. Our partners, those of you in the room, you know who you are as well. The Regional Office for Europe, WHO Europe, and WHO Country Office. The Stop TB Partnership has been integral here. And of course, the Mission Review members and our wonderful interpreters who have really helped make this happen. With that, I thank you very much for your attention.
Dear Tom, thank you for highlighting a list of key areas and findings and recommendations from NTP review. I'm very thankful, and I will repeat your words and yours and Dr. Parpives. I would like to thank the team here, the team in the provinces of Uzbekistan for their openness for providing a full set of information that made this NTP review and the mission very productive. This information will be sufficient for us to develop an effective document about the review. I would like to thank you, my colleagues in Uzbekistan, that the methodology of the NTP review is a new one. And right now, the global TB program in the WHO headquarters is publishing new guidelines on the mechanism for reviewing NTPs. So, the draft of this document was used to conduct a the NTP review based on this new methodology that will be the foundation for global recommendations on conducting NTP reviews. So this is the mechanism for intersectoral collaboration and accountability, and that will be also part of our new recommendations to address this serious problem. Thank you very much, Tom and Askar, who gave us the broad strokes and introduced us to the preliminary findings of the mission. But we understand perfectly that there are the challenges remain, and sometimes addressing them does not always depend on us, and we're thankful to the team that came as a mission to Uzbekistan. They didn't come as strict supervisors, but as experts. And our request to them was to pinpoint these challenges and help us to find ways to solve these problems. And I hope, Askar, that we didn't fail the WHO Regional Office for Europe, and your pilot was a success. We did do our best, and it's an honor for us, and we would be very delighted if we were able to create all the conditions for you to pilot these new guidelines on a new level. Thank you very much. Now, let me continue announcing the speakers. Now we're going to hear updated information on new WHO guidelines on management of TB in children and adolescents. We will ask Guy Blondon, WHO consultant, and our dear friend of our Uzbek team, who's come here several times and provided trainings on all the new developments. And before your presentation, I received many kind requests from our doctors, practicing doctors, where we will be able to see the presentation on YouTube. Okay, there will be access to that. We will take care of the technical details. You have the floor, Kai. Thank you. Thank you for the opportunity to be present at this conference and see many colleagues like you. And thank you very much for the introduction about me, dear Professor Parpiva. I will speak about childhood TB. I'm not a pediatrician myself, but I worked with child TB in my international experience for 26 years now. I can report about updated WHO recommendations that were published in March this year. As usually, WHO publishes new updated recommendations once every 2 years, and when recommendations are published, at the same time, the preparation starts to draft new updated recommendations to be published 2 years later. The same happened with these yellow recommendations, or books with recommendations. Rapid communications were published and then translated into Russian, and then in March this year followed the consolidated guidelines and operational handbook on tuberculosis. Now, if you look at I'll look up on WHO website, you will see the Russian guidelines. It's a quite a voluminous document, and you will see what's been updated and what's still remains. It's difficult to cover everything, but I will speak about one recommendation. Otherwise, I would be speaking here until tomorrow. In new recommendations, we have 2 on diagnostics and 4 relating to treatment. In this book, there's also a summary of new and old recommendations and the changes that were made, and this is a very useful table at the end of the guidelines. But at this meeting now, I would like to not read the list, but what needs to be grasped from this book and make a reality for our children in their homes or where they reside. One of the most important points about diagnostics is that we can use the same rapid gene expert MTB RIF Ultra for gastric aspirate, but what's more important, and we can use it for stool samples for diagnostics of pulmonary TB and resistance to rifampicin. It's very important for children. We don't want to traumatize them. It's easier for their mothers and fathers because they see that their child is not being traumatized or injured. And it's easier for doctors to get these samples, that you don't have to put tubes in the child, but you can just receive a stool sample and do this test. So it's a revolution that this method or this assay could be used to examine or test stool samples. So my call for doctors and lab specialists to quickly implement this in practice so that children have access to easier testing. So the strength of this recommendation is high, so you shouldn't have any doubts about it. The second recommendation applies to treatment. So I will tell you about these recommendations as they as much as they are important in real life. The most important point in treatment is to shorten the time of treatment of children. Before now, we were to treat them for 6 months. Now, there is an opportunity to treat them or to cure them in 4 months. So this is 2 more months of 2 more months found for the lives of children. What's the basis for this regimen? Well, it looks almost the same as ethambutol in quotation marks. I think that in countries like Uzbekistan, where the resistance is high, or in Africa, where there's a lot of people living with HIV, then ethambutol is advised to be part of this regimen. So if I were a queen, and I could rule, and I would recommend that Uzbekistan uses 4, not 3 drugs, and for 4 months. So this study was called SHINE, short treatment of minimal tuberculosis in children. So it's a shorter treatment of minimal TB. What is minimal TB? That's a subjective concept to some extent. There's also a definition and eligibility for children to be enrolled into this study. So tuberculosis of lymphatic nodes, peripheral lymphatic nodes, and also of the right lymphatic nodes without obstruction of respiratory tract, and uncomplicated TB, and pleural area, and scarcely bacillary and no cavity disease. So it's a limited process, or the process could be limited to one lobe of the lung. So this was a larger review in many countries, and they tried to enroll children who didn't have confirmed TB. These were children under 16 years of age, and they were divided into 2 cohorts. One cohort received TB treatment for 4 months, another one received it standard TB treatment for 6 months. So they tried to exclude everyone who had a positive smear result. And the goal of the survey was to see if this was not a disseminated process, if it was a regular children that we regular process that we observe in children, then the 6-month treatment regimen has good results. But we wanted to see if we shorten it by 2 months. then maybe the 4-month treatment would be as effective and we wouldn't see negative results, even though we'll treat them for shorter time. So we wanted to see if this 4-month treatment regimen will be as safe as the 6-month regimen. So the results. In both groups, treatment failure rates were the same. Almost 600 children were in both groups, so it was these were large cohorts, and reliability is always high. It is also high. So it was decided that the 4-month treatment regimen will be as good as the 6-month treatment regimen for those children who do not have disseminated TB. We thought that Uzbekistan could adopt it as regular treatment regimen in the country. Now, moving on to treatment of meningitis in children. Here, WHO proposed recommendations, but again, if I were a queen in Uzbekistan, then I would start prescribing this treatment regimen. Prescribe this treatment regimen right away. This should be considered as an alternative. The older treatment regimen for meningitis, 2 months, 4 drugs, 10 months, 2 drugs. This is also part of your national guidelines. It's as good as the newly proposed one, and you can continue. Why is it recommended to adopt the 6-month treatment regimen with etianamide instead of ethambutol? Because the thought here is that etianamide has a good capacity to overcome hematoencephalic barrier. The mortality was found to be lower and treatment success is higher, but there were more frequent neurological consequences as compared to the regular treatment regimen. But in a situation with high resistance in this country and in the post-Soviet countries in general, we're not sure to which extent this treatment regimen is going to be effective. You just keep this regimen in mind. If you have a patient that could benefit from this treatment regimen, then you can opt for this one. When you start using the 6-month regimen, look at the doses. The doses are listed in the book, and they're higher than usual. And I shouldn't be probably saying this directly, but on the 30th of September, a book on doses for childhood TB. The book was published, and the doses for children under 3 years of age were added to this book, or under 5 children. The doses here are higher because the metabolism in children is faster. Now let's speak about adolescents. They're, on the one hand, they're children, on the other, they are not. So adolescents are divided into two groups, 12 to 16 years of age and older than 16 years of age. And some countries call them adults already if they're older than 16 years of age. There's a bit of a problem here, not because they're different, these children are different. The fact that different research works include children of different ages. So we have regimens. So it looks like some regimens are meant for children under 14, from 14 to 16 years of age, and other regimens are meant for children older than 16 years of age. Well, actually, you can use a regular 6-month treatment regimen to all of these children. Then the same 4-month regimen from SHINE study that I just mentioned, it can be prescribed to both groups as well. But those children, age 12 to 16 years of age, I'm sorry, no. The SHINE study regimen can be prescribed to children from 12 to 16 years of age, but both groups can be prescribed the regimen that is based on study 31, which we will discuss later. And it includes isoniazid, rifampicin, pyrazinamide, and moxifloxacin. So I will stop here because other speakers, including Elmira Gurbanova, so in her video message, she will discuss those issues. So this study included 63 adolescents, and the results of this study could be extrapolated to adolescents. And so there were 3 groups of regimens, one standard control, then one with rifampicin only, and the last was rifampicin plus moxifloxacin. So both were included in the regimen, moxifloxacin and rifampicin. So the results were equally good compared to the regular control group. So I will not tell you more because that will be the key point of the following presentation. As for DRTB, so on children we have only 2 slides here for drug-resistant TB, but the slides are important, which means that bedaquiline could be officially given to all children under 6. Before we had that problem if we can give it to children under 6, and now WHO says, okay, you are free to use bedaquiline in children under 6, and we have limited data, and mostly one review included only 12. Plus, we have some other studies and also from databases on countries. We collected all the patients. We have 40 overall. The cohort is not that big, but they had no issues with bedaquiline. So bedaquiline could be given to children all ages. And then some caveat. If you have a child with extrapulmonary TB, in addition to TB lymphadenopathy, so longer regimens are preferable. And the last slide is on Dilamanid. Again, Dilamanid can be given in children of all ages. Dilamanid is not used in shorter regimens now, and when you develop your regimen for children with Dilamanid, well, it should be case specific and the regimen should be longer. So Professor Parpieva and Hassan asked me to make this presentation on pediatric TB and provide new recommendations, and after I wrote my slides during this mission, I had a good opportunity to develop the most important aspects of that yellow publication, what needs to be presented at this very conference, and Jennifer Ferrin, who has many years of experience in treating children, she really helped me to focus better on those issues in my presentation. Thank you. Thank you, Kai, so much for your excellent presentation, and I guess our specialists might have questions, and at the end of this session, please answer their questions. And the next presentation will be made online. Elmira Gurbanova, WHO Europe consultant, she will present WHO recommendations for short-term treatment of drug susceptible to be in adults and children. I hope our technical support people will help us
quickly show the presentation. Well, good afternoon, dear colleagues. I am happy to have this opportunity to speak at this conference. Thank you, organizers, for your invitation. I'm Elmira Kurbanova. I'm an international consultant on TB. Today, we have a lot of discussions and a lot of work on making those Nargiza. Well, the recommendations were issued in 2022 in the new guidelines for DSTB treatment, and this recommendation says people aged 12 and over with DSTB can receive 4 months treatment regimen with isoniazid, rifampicin, moxifloxacin, and pyrazinamide. So, and we need to note that this course is recommended for program, and this WHO recommendation is evidence-based, as are all of its recommendations. And so, study 31 findings were the basis for this recommendation. The findings were based in one of the reputable medical journals, that was the Open clinical trial, phase 3, with more than 2,500 participants from 34 clinical centers in 13 countries. Most of the participants had pulmonary TB with a confirmed susceptibility to isoniazid, rifampicin, and fluoroquinolones. So the age participants were aged 12 and over. So this study compared 4 months treatment regimens based on rifampicin with the standardized 6 months treatment regimen, which we are currently using broadly in routine practices to treat rifampicin susceptible TB. The primary signs of effectiveness or survival without TB after 12 months following randomization. So the primary indicator for safety was the share of participants with adverse events, grade 3 and over, throughout the treatment course. The rationale for making treatment regimens shorter from 6 months to 4 months. So the findings of the study, which showed the decrease of the viral load, and in fact this regimen can be a promising strategy for TB treatment, plus rifampicin has shorter has specific characteristics which make it possible to make the treatment regimen shorter from 6 months to 4 months. So these are the key characteristics of the study. Participants, how they are similar to the characteristics of our patients we treat in routine practices. So more than 70% of all the participants had caverns in lungs, and more than 80%, in addition to positive culture, had also positive, they were sputum smear positive on microscopy, which suggests that that was quite a challenging cohort. So with quite severe forms of disease. So in the group that received rifampicin, moxifloxacin, 84.5% of patients were cured. In the control group that received 6 months treatment regimen, this rate was 85.4%. So as for adverse events, grade 3 and above were reported in 19.3% of participants in control group, and in 18.8% in the group that received rifampicin and moxifloxacin. So the study confirms that this 4 months treatment regimen was equally effective as the standard 6 months treatment regimen for DSTB. Once again, currently WHO recommends use of 4 months shorter treatment regimen for drug-susceptible TB treatment. But for program-based use, we need to make sure that this treatment regimen is prescribed to the target group of patients. So what are the criteria for exclusion? What are the contraindications like for this treatment regimen? And WHO recommends against the following groups: patients with weight less than 40 kilos, since low weight might suggest severe forms of TB, and their subgroup. For this subgroup, maybe a 6-month treatment regimen might be preferable because we have more experience in using that. And patients with extrapulmonary TB, TB meningitis, disseminated TB, TB of joints and bones, abdominal TB. So these are also the subgroups where we do not recommend currently this 4-month treatment regimen. And you might have noticed that some of the participants had TB HIV co-infection, and the results of the shorter regimen. And people with HIV and without HIV are comparable, but people living with HIV and with CD4 cell count less than 100 per cubic millimeter, well, for those patients, you better give 6-month treatment. And children, adolescents under 12, pregnant women, breastfeeding women, postpartum women, well, they are also a subgroup that are excluded from this 4-month treatment regimen, since currently we do not have enough data on use of this regimen in this subgroup. Let us discuss the doses which are suggested for those treatment regimens: pyrazinamide, rifampicin, isoniazid, and moxifloxacin. So these doses are standardized, and actually rifampicin. So the recommendation is 1,200 milligrams.
Использовать при, допустим, профилактическом лечении.
So this is what we are used to when we give rifampicin for prevention, and on top of that, this regimen also includes the so-called intensive phase, when patients receive all 4 drugs, in the continuation phase without pyrazinamide. And so 8 weeks intensive and 9 weeks continuation phase. So we use only moxifloxacin from fluoroquinolones, and I anticipate your questions, and I would like to say that currently WHO doesn't recommend replacing moxifloxacin with levofloxacin in shorter regimens, and plus WHO recommends against prolonging this drug after 4 months, this treatment regimen. And when the national TB program takes political decisions to use 4-month treatment regimen for DSTB, there are several aspects which need to be planned in advance, which need to be financed in advance. And we will discuss those aspects. First of all, this is the diagnostic algorithm. So currently, in many countries, in line with current WHO recommendations, the diagnostic algorithm suggests that all patients with rifampicin-sensitive TB should have the results of the rapid molecular tests. For isoniazid susceptibility, and in case of resistance to isoniazid, rapid molecular tests should be done to identify resistance to fluoroquinolones. So this is done to make sure that mono-resistant TB, resistant to isoniazid, could be treated with 6-month treatment regimen. And statistics suggest that in our region, some 10% of all patients have mono or poly-resistance to isoniazid, which tells us that some 10% of susceptible patients will be resistant to isoniazid and will require additional rapid testing to fluoroquinolone resistance. And while discussing introduction of shorter treatment regimen for DSTB, one of the criteria should be noted, which is confirmed susceptibility not only to isoniazid and rifampicin, but also to fluoroquinolones, which means that if the country uses a 4 months treatment regimen, then all rifampicin susceptible TB patients should have results of the rapid testing, not only to isoniazid, but also to fluoroquinolones resistance, which means that more tests will be used and more financing will be required. But fortunately, now many countries, including Uzbekistan, are introducing expert XDR, which makes it possible to quickly identify resistance not only to isoniazid, but also to fluoroquinolones. In addition, it is important to note higher costs of the drugs in this 4 months treatment regimen, which is mostly associated with the cost of moxifloxacin and rifampicin. And if we compare the costs of 4 months and 6 months regimens, actually, these can be more expensive, like 4 times more expensive. And in fact, well, some of the drugs have been used for a long period, and some fixed presentations are available when one pill can be taken and it will contain all the 4 drugs. As for 4 months treatment regimen, monocomponent drugs are supposed to be used plus rifampicin, given that the daily dose is 1200, then it is available at 150 or 300 milligrams. So the number of pills to be taken by a patient daily, well, it's quite considerable. So several pills need to be taken, which might represent some barrier for implementation. And plus 4 months regimen implies daily administration of drugs, which means daily control of taking pills, and special attention should be given to such support measures like video observed treatment, support to adherence, plus rifampicin is better absorbed in the intestine if fat foods are used, and we also need to take that into account because we might have some socially vulnerable groups in need of extra support, including foodstuffs. Thank you. Thank you so much, Elmira. We are happy to see you at least online. Unfortunately, you couldn't come to us, but anyway, thank you so very much for your time, for making this presentation. And we hope that soon you will come to us if we have questions to you. I hope if you have time, you will be able to answer them. Thank you. Oh, well, I was told that Alexander Karotic will also make his presentation online. So he is technical officer at WHO Europe. He participated in NCP review, but he left the country, and he will present the overview of the WHO Regional Office for Europe Initiative on co-management of MDR, TB and rifampicin-resistant TB plus viral hepatitis C in operational research settings. Please, Alexander.
Коллеги, там была запись выслана, вы не получили мою...
Colleagues, have you received the record of my presentation? Colleagues, I can show this video on my side. Yes, Alexander, as we understand, we don't have your video here. Well, I can see, no, they are saying we have it. Just a minute. Yes, we have it.
Что лекарственно-устойчивый туберкулез является огромной проблемой здравоохранения.
Drug-resistant TB is a problem in the WHO region. In 2020, the WHO has identified countries with 30 countries with TB as priority, and 9 of them are in the European region. Azerbaijan, Belarus, Kazakhstan, Kyrgyzstan, Republic of Moldova, Russian Federation, Tajikistan, Ukraine, and Uzbekistan. Each of these countries annually diagnose more than 1,000 new cases of MDR-TB. It should be also pointed out that the burden of MDR-TB in our region, 97% of them counts for these countries. In addition, in WHO European region, that is half of global burden of pre-XDR TB, MDR resistant to rifampicin and fluoroquinolones. Hepatitis C is also an important challenge for health systems around the world. Based on WHO estimates globally, annually, there are 1.5 million new cases of hepatitis C and 290,000 deaths. Our region is the second region when it comes to incidence, 300,000 annually, and mortality, according to estimates, 64,000 people. This slide shows categories of the population with high prevalence of viral hepatitis C or have high risk of infection, and that's according to WHO data. In these categories, there are also those who have high risk of developing tuberculosis. So these are people who are using or have used drugs, prisoners or ex-prisoners, and also people living with HIV. At the same time, the prevalence of hepatitis C in TB patients is not very well studied. This slide shows a publication which is review of 21 studies in 4 geographic regions of WHO, European, American countries, Southeast Asia, and others. More than 15,000 patients were included into these studies, and the prevalence of hepatitis C in patients with TB varied from 2 to 27%. And cumulative prevalence was about 70%. The confidence interval is 6 to 95%. The screening for hepatitis C in TB patients is very important. Information about the presence of infection caused by viral hepatitis C may help success of the treatment. There's a need for urgent measures to raise awareness of people about screening for hepatitis C in patients with TB. This is the list of countries which were included into the review shown on the previous slide. In our European region, there was only 1 country, but 3 studies were included into this review. And this country is Georgia. Prevalence of hepatitis C in TB patients is from 12 to 22%, depending on the patient cohort that was described. Until recently, this used to be the only information about prevalence of viral hepatitis C in TB patients or patient with MDR-TB in our region. Nevertheless, some progress has been made, and thanks to the WHO Regional Office for Europe, different studies were initiated and which described the prevalence of viral hepatitis, in particular viral hepatitis C. These countries are Belarus, the Russian Federation, Georgia, Ukraine, And these studies pointed out that viral hepatitis C occurs in 15% of patients with MDR and XDR-TB in Belarus, 12% of patients with MDR-TB in Georgia, 19% of patients with XDR-TB in the Russian Federation, and 3.5% in Ukraine in patients with DR-TB. But back then in Ukraine, there was no universal testing for hepatitis C in all these patients. That's why these figures are lower than expected. For many patients, the hepatitis C status was unknown. But starting in 2020, at the WHO Regional Office for Europe, together with 13 countries, in our originally studying modified short-term treatment regimens. And under this study, testing for viral hepatitis C is compulsory. So during the study, in further analysis of the characteristics of patients enrolled into the study, new information was obtained that about 11% of patients with DR-TB with sensitive to fluoroquinolones have hepatitis C. This percentage varies among the countries, or from country to country, from 2% to 30%, but still is quite high. Now, this data made us think about the role of hepatitis C infection during anti-tuberculosis treatment, and we found this publication on PubMed. This is the resource where you can look up information in the area of medicines, even with normal initial biochemical parameters of liver. Co-infection with hepatitis C means longer exacerbation of during treatment with drugs for TB. So screening for hepatitis C before initiating a TB treatment may monitor the periodicity of the treatment of TB. So hepatitis C is a direct factor that may be related to medicine-induced hepatitis. This is a statistically proven pattern and described in studies. Another publication, it describes the experience of using bedaquiline in Armenia and Georgia. It says that viral hepatitis C with multi-drug-resistant TB leads to less successful TB treatment, and researchers who wrote this publication point out that diagnostics and treatment of viral hepatitis C should be considered for patients with MDR-TB. This table from the previous publication clearly shows that there's a direct statistical link between treatment failure in patients who were on bedaquiline and presence of antibodies in them for hepatitis C. This speaks about simple logic that we need to diagnose viral hepatitis C and treat viral hepatitis C so to avoid hepatotoxicity and improve treatment outcomes from MDR-TB. As you know, in 2020, the WHO guidelines were updated. This is on treatment MDR-TB. In particular, a new grouping of drugs was proposed for treatment of MDR-TB. The priority drugs are the following. These are the ones that showed the best effectiveness and least toxicity. These are Group A, levofloxacin, moxifloxacin, bedaquiline, linezolid, and Group B drugs, clofazimine and cycloserine. These are the key priority drugs that need to be used for individualized treatment regimens. In addition, the same drugs are used in the operational study of modified short-term treatment regimens for drug-resistant TB. Majority of countries from Eastern Europe and Central Asia have good access to using direct action drugs for treatment of hepatitis C. these drugs quickly and effectively cure patients from hepatitis C. In available WHO guidelines for treatment of rifampicin-resistant TB or treatment of viral hepatitis C, there are no clear recommendations for management of both diseases at the same time. Still, if we use these resources for drug interaction such as Medscape and compare if there's any interaction between second-line drugs and Group A and Group B drugs for treatment of rifampicin-resistant TB, we will find that there is no interaction between these drugs. So two diseases can be realistically treated at the same time. On the previous slide, we saw data from Medscape, and here we're showing a tool for checking drug interaction for treatment of hepatitis that was developed by Liverpool University. Here we can also see that between second-line drugs and direct action drugs for treatment of hepatitis C, there is no interaction. There's only potential interaction between bedaquiline and lidosphere and sovitosphere. When these drugs are used together, it is ECG needs to be done more frequently, and transaminase needs to be monitored. If we do the same check for first-line drugs for treatment of TB, we will see that there's a lot of drug interactions. But in case of drugs for treatment of MDR-TB, we're in a more advantageous condition because this treatment is possible and shouldn't be causing any undesired or adverse effects. It should be also said that within many programs in many countries, joint testing or joint screening for viral hepatitis C, HIV infection, and TB is done. In particular, in Georgia, this is done. And this helps us to detect viral hepatitis C infection. And once it's detected, we can treat this in patients with MDR-TB. And we started thinking here, what's the best way to implement the joint management of viral hepatitis C and MDR-TB cases in our countries? Since there are no clear recommendations from WHO, it's best to do this within the frameworks of an operational study to collect harmonized data from the countries and then submit this data to the WHO group for consider recommendations to see if the safety of this treatment is confirmed. Once this is done, then there will be a recommendation about programmatic implementation of joint treatment. So this combined or joint treatment, different resources and new resources can be used for treatment of TB, that is video supervised treatment, so we can utilize it for treatment of hepatitis C. And now in September 2021, we came out with an initiative to conduct a regional operational study for simultaneous treatment of hepatitis C and MDR-TB. We put together a group of experts in the areas of TB treatment, hepatitis C treatment, to work on the study, and we instructed this group to develop a package of documents for the regional operational study that consists of the study protocol, clinical guide, and the guide for management of or monitoring of adverse effects, and a checklist for evaluation of the preparedness of the country for combined treatment, and also the data collection tool. We opened up this initiative for 18 countries, which had which consider TB control as the highest priority in the WHO. Armenia, Belarus, Georgia, Latvia, Republic of Moldova, and Ukraine, and also Kyrgyzstan is interested in. And maybe other countries will consider the opportunity to join this study, in particular Uzbekistan, based on the results of the evaluation of the national based on the NTP review results. So you have data for screening hepatitis C patients, and we believe that this is a good starting point to implement and jointly treat both illnesses. The next goal under this initiative is to promote effectiveness of treatment of MDR. We see that untreated hepatitis C influences treatment outcomes, negatively influences treatment outcomes. And also the next step would be to start using direct action drugs for treatment of hepatitis C in MDR patients. And next one will be to streamline collaboration between TB service and the service for prevention of hepatitis C, that in the countries which will improve quality of clinical care for patients with co-infection, and also enrichment of global knowledge about safety and effectiveness of this type of treatment, and develop relevant WHO recommendations. So data needs to be collected and submitted to WHO for development of future recommendations, and then so that joint treatment could be recommended as part of programs. Well, under this study, we'll use a simplified schedule of monitoring patients, since two diseases are treated simultaneously. Some procedures of monitoring treatment do not have to be repeated. So this uniform treatment regimen will help us to achieve some savings when two diseases are treated. So under this initiative, we will promote injection-free treatment regimens, and thanks to this joint treatment, we will reduce the risk of liver damage in patients with co-infection, and we will reduce the risk of adverse outcomes of treatment or failed treatment failures, and we will also use drugs for treatment that do not interact with each other to prevent the risk for patients of adverse effects. Under implementation of this initiative, WHO will actively support the countries. Well, we've already developed a regional package for this study, and we will help with adaptation of this package to each country context, which desires to start this study, and we will receive approval, help with receiving approvals from the ethics committees, and we will help with monitoring during the study, and we will provide any methodological guidance needed during the study. Methodological assistance in data management, and we will provide monitoring. And under this initiative, there will be an opportunity to use the virtual medical consilium if there are questions for joint management of these both diseases, because virtual medical consilium will be attended by specialists in hepatitis C. In addition to the immediate goals of the initiative, we have the goals of the study. The following goals were identified by experts. The main goal is to identify the effectiveness and safety of co-therapy of patients with TB and hepatitis C, and secondary goals is to identify the frequency and the timelines of emergence of serious adverse effects and the regular adverse effects in patients who receive combined treatment, and identified predictors of treatment failures for MDR-TB and DR-TB patients, and then identify predictors of treatment failures of treatment of hepatitis C. And the last one is to evaluate the roadblocks and factors that the factors that are considered the programmatic and rollout of the scale of treatment of hepatitis B for patients with co-infection of MDR-TB and DR-TB. So doctors and stakeholders and patients who will be involved, thanks to this component, we will be able to find out when this initiative becomes programmatic, what needs to be taken into consideration so that this program is successful. This slide shows a list of documents of the regional operational study. This is the protocol that includes a qualitative module that I mentioned before, which is about identifying something that can prevent or something that can promote this kind of treatment, the form and data collection form on safety, and the schedule of monitoring of treatment that is harmonized and helps us to avoid duplication of clinical procedures, and patients who will receive treatment for both diseases at the same time. We have clinical guidelines as well for management of adverse effects, and clinical guidelines for joint treatment, and informed consent form, data collection tool. So we have the red cap system, which is convenient. You can easily fill out the forms and check the data quality. We also have educational materials for patients, budgeting tool, and the tool which I've mentioned, that's the preliminary country assessment tool, which will help the country to analyze all relevant aspects. So the study could be carried out. And so joint treatment TB hepatitis C could be provided. So now we are at the stage when the preliminary protocol has been finalized. It's being analyzed by countries, and the protocol was submitted for review to the WHO Ethical Committee. It was coordinated preliminarily, and hopefully this protocol will be approved, and the first country, Belarus, can start enrolling patients, and thus the other countries can follow this example, can finalize the protocol, can get approvals from local ethical committees and from WHO ethical board, and they can start implementation. So we hope that countries willing to participate in this initiative will finish the preparatory work, and they will start the enrollment. And they will enroll patients during 1 year, and the patients will be treated against 2 diseases at the same time. MDR and TB treatment will depend on the regimens available in the country. So if MSTR, longer regimens, or BPAL are available, they will be used respectively. Duration of treatment as part of this initiative will depend on the duration of the MDR TB treatment, and that's why you can see quite long timelines for this study. Well, definitely most of the patients hopefully will be treated with shorter regimens, and we might also have patients on longer regimens, and because of them, the duration will be considerably longer, which will also increase the timeline for our initiative, and we will also track the outcomes for another 12 months to detect reinfection cases, and thus we hope that by early 2026 we will fully finalize data collection on patients, collection of data on patients, and hopefully we can provide the data to the WHO group on development of recommendations for analysis. And the expectation is that in the second half of 2026 we will also discuss it with the health professionals, with the patients, so their experience could be discussed and described to identify the barriers, the enabling factors, so in the future that treatment could be provided on the program basis. Thank you. I hope this presentation was interesting and useful, and I also hope that Uzbekistan will consider joining this regional initiative. Since all your patients are tested for viral hepatitis C, that will be really instrumental, that opportunity for a joint treatment, like co-management of those infections. And my dream is that those patients with TB and Hep C could be co-managed well. Hopefully we will do this
together have a successful conference. Thank you very much, Alexander Karotic, for your nice presentation. And if we have questions, I hope you can stay with us to answer them. And the next presentation, well, we were supposed to have presentation by Alena Skryagina, but since that will be online, and our dear Professor Andrei Maryandyshev tomorrow morning is supposed to leave, and we scheduled his presentation for tomorrow at 3 p.m. and we decided we switched them. So Andrei Olegovich, the floor is yours. Shorter treatment, MDR-TB treatment regimens and the Russian Federation. So he came from Arkhangelsk, and he's head of the Tibetan pulmonology department of the University, Northern State Medical University. So Andrei Olegovich, the floor is yours. Microphone, please. So, dear colleagues, thank you very much, Nargiza Nusratovna, for this opportunity to speak at your conference, and best wishes from my colleagues. And actually, I'm from the Arctic region, but you had +5 like we do in Arkhangelsk. Yes, we try to make it comfortable for you. Thank you so very much, and also I would like to thank the heads of sessions, the moderators. Thank you, Oskar, for an opportunity to speak at this session, and I will continue with WHO recommendations about those shorter treatment regimens without injections, but I also would like to share the experience which we got when using those shorter regimens. I would like to remind you that we have this very good slide from WHO when the treatment success goes down with increasing drug resistance. So immediately we can see the results. Now we have new drugs, bedaquiline and others. They are at the stage of post-marketing studies, and most importantly, we have the research findings which are the basis for WHO recommendations. And I would like to remind you that we have the new recommendations for MDR and TB treatments based on TB Practical, Zinix, Stream 2 regimens, and this combination of drugs with new drugs so makes it possible to recommend new regimens. And the latest consolidated recommendations by WHO. So I would like to remind you that we have item 6 of this handbook. So it says that any patient, child or adult with MDR-TB is eligible for treatment with a shorter treatment regimen. So any regimen containing bedaquiline, but if it's a longer regimen, well, you can do it only if shorter regimens are not possible. I would like to share some experience how the shorter regimens can be used in the absence of some legal framework. For example, your clinical recommendations do not include such regimens. I would like to share some experience how it can be done in that case. So as of 2020, so bedaquiline and delamanid could be used simultaneously, and new drugs were recommended in that summary. And I'd like to back then we were using XDR-TB, pre-XDR-TB. We had that terminology. Now we understand that actually this is the same cohort, and I would like to share some findings about the effectiveness of treating them with bedaquiline, delamanid, linezolid, and clofazimine. Registration of patients. I live in Arkhangelsk province, so 1 million population, more than 1 million actually, and the number of patients as of 2018, 2019, 2020, MDR-TB, pre-XDR-TB, well, definitely all TB patients were tested. So DST is done for all of them. We had 28 XDR-TB patients and 4 MDR-TB patients were enrolled in this new treatment regimen using 4 new non-injection drugs because for some reason they couldn't tolerate levofloxacin, and that's why this group of patients. Yes, I managed to change this slide. So shorter treatment regimens, 12 months regimens, include bedaquiline, linezolid, clofazimine, dolamanid. So all patients with pre-XDR were enrolled. So no other patients were left without that regimen in our province, so they all were enrolled in that shorter 12 months treatment regimen. We are grateful to MSF because they helped us with drugs, since many drugs were not registered in the Russian Federation. So we had 2 drugs which were not registered, so the dolamanid is now registered, back then it was not, and they helped us. So that project was as part of compassionate use. And so for life indications, that's how it sounds in orders of the Ministry of Health for all patients. So the categories. Actually, we have various categories. So new cases. We also had failures, and we had those coming from other provinces of the Russian Federation. That's why we had all types of patients. Traditionally, for XDR-TB patients, for pre-XDR-TB patients, actually the characteristics are the same as other patients share. Well, I apologize, I skipped the slide. Well, it's not me doing this. Okay. I apologize. I'm sorry. So, those who interrupted treatment, those who were repeatedly treated, and the treatment outcomes, 65% effective chemotherapy. Also, we had those who interrupted treatment, then treatment was ineffective in 2 patients because we were afraid of resistance to those drugs. 5 patients died while receiving the therapies. Those who died from the intestinal hemorrhage, then esophageal cancer, terminal stage of HIV infection, and alcohol-induced cardiomyopathy. And in this presentation, I would like to say that, unfortunately, the dolamanid, which is registered in our country, is not included in Group A. It's in Group C of our drugs. And I'd like to remind you that dolamanid, like isoniazid, kills bacteria, and also it has that sterilizing effect like rifampicin, and that's why it's a decent drug. And unfortunately, I guess it's not fair that this drug is in this group C, I guess. It's been 5 years since we adopted that classification, and it's high time to revise it. So as for meta-analysis of dolamanid use, this shows that dolamanid was effective. So 25 studies were conducted. They met the criteria, 22 observational studies, so all patients had MDR TB, and 80% of observational studies confirmed that that was effective. 72.5% of trials also confirm effectiveness of the Delamanid. As for age groups, 74% of people under 40, 85% of people over 40. In children, the therapy effectiveness depended on, so actually it depended on sex, and in children it was even higher. And bedaquiline can also be used in younger children. The effectiveness is high. And the last point, bedaquiline plus Delamanid, 75% is the total for treatment success in meta-analysis. And as for safety, well, longer QT interval, which is our greatest concern, was reported in 12% of cases. Mental disorders 7.1, intestinal disorders 4.1, peripheral neuropathy 3.5, renal failure 2%. Well, I guess operational studies which can be conducted where this drug is not yet registered. Well, here you can use a combination of bedaquiline, Delamanid, clofazimine, linezolid, so as part of operational studies. And as I said before, well, for as compassionate use. And 66%, as I said before, was the effectiveness based on our study findings. And this meta-analysis has shown that the Delamanid definitely should be included in Group A because of its high effectiveness. Thank you for attention. Thank you for this opportunity to speak at this conference. And once again, congratulations on this anniversary. Thank you, Andrei Olegovich. And I wanted to draw your attention to the following. We also have our speakers online with us. And if you have questions, first of all, to those who are online and to all those who made presentations at this plenary session. Was it all clear? Yes, please. I guess we have the microphone. Kyrgyzstan, Dr. Golova. My question is most likely to Oskar and to Elmira Gurbanova. So we have a lot of new information on detection on new forms, except for polyresistant TB. Well, as for new clinical guidelines of the WHO, which is expected this year and or next year, can we expect something with regards to new treatment regimens for polyresistant TB management? Thank you. Thank you for your question. As I understand, this question is about polyresistant TB. Well, I'd like to say the guidelines which we expect any minute will not contain any new information on polyresistant TB. So far, the recommendation by the WHO for management of polyresistant TB is the recommendation from the 2014 guidelines. I do understand your question because the previous guidelines also include injectables for polyresistant TB management, longer periods for treatment, and now when treatment regimens tend to be shorter and shorter, and we are moving away from injectables. Yes, definitely the point is about using shorter regimens for those forms of TB and to treat the polyresistant TB with amikacin. Well, it doesn't sound realistic any longer. And my answer is in the coming guidelines, no changes will be presented with regards to poly-resistant TB. But as for what is going on in Uzbekistan, I could see that, and I was happy to see your national guidelines. And as for poly-resistant TB management, the recommendation is to use new drugs based on the priority drug. Well, lead or clofazimine are added, and you recommend against injectables, which is logical, which is only appropriate. And my expert opinion is you are doing it correctly. But WHO so far has no new recommendations. By the way, Dr. Yedilbaev is here with us.
We've already had discussions on this topic. Maybe Dr. Yedilbaev will either take this question or maybe provide updated information about the future developments. Thank you for your question. Elmira, thank you very much. I don't think that I will be able to give any more details to what you have said about the new guidelines. Well, the updated guidelines on treatment of DRTB is to be expected by the end of this calendar year. This is the little update from headquarters of WHO, but we've heard the question. We will convey to the level of headquarters of WHO. And there was also the call for countries to share their data for the next group to develop recommendations on poly-resistant TB. Please, one more question. Nazgul, UNICEF, Uzbekistan. I have a question about diagnostics, and I hope that the WHO experts will be able to answer. This is about using GeneXpert cartridges. Well, my question is as follows. Are there any other alternatives in the nearest future to this, considering the fact that waste management of these cartridges is an environmental problem, and also the issue of the price of the cartridges, which is quite high? What is the opinion of WHO on this, and are there any plans to offer other diagnostic solutions to diagnose TB and drug-resistant TB? MSF has experience of using, or we started using GeneXpert cartridges for diagnostics of hepatitis C. And once we had an opportunity to use Abbott, then we were able to do so because waste management of Abbott reagents is more feasible, environmental, sustainable. Mikhail is proposing there's a whole session on laboratory issues, maybe, and there's Harold is among us. Maybe we could listen to him. We'll probably do this. We will have the opportunity to discuss laboratory related issues and discuss this question during that lab session. Thank you very much. I don't have any questions, but a small comment, something to add. I would like to express my gratitude for NTP review team and WHO for the work that they have done, beginning remotely and then in person in the country. Most important point, which is evident from those preliminary recommendations that they developed, that this review is structured in the following way. It speaks about what is being done in the country and what good things are being done in the country. So it helps us to zero in or focus in on those areas that need this. So that motivates the country and colleagues who, first of all, see that their work and progress is being appreciated. So I would like to thank everyone who took part in this review. And I think that once we have the final findings of the review and recommendations, we will learn how we will be able to implement the recommendations that you will give us. Colleagues, if you have no further questions, I think that, well, the coffee break has been served already, but I think that we'll have a very good lunch. But I think that let's organize one festive part of this event. It will take several minutes. I hope you don't object, but it's a pleasant part. As we prepared our own national traditional gifts for our colleagues who've been working with us for many years and contributing numerous efforts to control TB in Uzbekistan, but it doesn't mean that others are investing fewer efforts. Just this time, we decided to so-called, that's an Uzbek term, to chapanize, to put on the chapan or the national gown on our colleagues. I would like to invite Askar Edelbayev. I think that he will make a very handsome young man wearing a chapan. He's ethnically Kazakh, but he will be a very handsome Emir of Bukhara. We unfortunately cannot hear Dr. Parpiva in the booth. Sorry, no input. No input in the booth.
Спасибо, спасибо.
Thank you so much. There's also a kind request from the Kyrgyz delegation. They would like to now congratulate us on the anniversary. Dear Nargiz Nusratovna, dear colleagues from the Uzbek team, Uzbek TB doctors, on behalf of the delegates from the Kyrgyz Republic, we congratulate you on the dual anniversary, so that next time we celebrate your achievement, so that we envy in Kyrgyz Republic and think when we achieve these results as Uzbekistan. So I hope that during the next conference that you hold, you will announce that you have eliminated tuberculosis. So, and for this to happen, I wish you good health, peace and friendship in your families, and all the best in this endeavor.
легкие, вехи и так далее. Please.
Thank you very much, Professor Papillova, and thank you so much for giving me the opportunity to speak here on this excellent conference. I enjoyed so much to be here, and it's a great, great honor to have the opportunity to talk about a purely microbiological topic. And I hope very much that I still find the interest of you as a clinician as well as of the auditorium. Well, evolution of resistance started together with the evolution of the antibiotic drugs against tuberculosis. And the first clinical study on the first antibiotic against tuberculosis was published in 1984 on streptomycin. This is the first clinical study ever on anti-tuberculosis drugs, and the authors had very promising results with more than 50% improvement of the outcomes, but they also observed quite a substantial number of resistances, up to 70% of the bacteria that they recovered from the patient evolved resistances towards streptomycin. And before they started treatment, they had 1 out of 90,000 bacteria recovered from the patient with resistance towards streptomycin. But already after 5 weeks of treatment, this percentage increased to 1 to 367. This taught us, first of all, that when you treat with a single drug, you risk to...
Если вы используете один препарат, то быстро может развиться устойчивость. Второе, когда вы сталкиваетесь с устойчивостью, вы всегда сталкиваетесь с комбинацией бактерий. То есть есть и устойчивые, и чувствительные бактерии перед вами.
The new drugs which have since ever been developed had the same destiny. They were published, and shortly after, the first resistances were reported. The good news is we have now a bunch of antibiotics in the pipeline in phase 2 and phase 3 studies. But the bad news is that at the same time we have this explosion of multi-drug resistance since 2000, which is spreading all over the world. Every resistance comes from somewhere inside of the bacteria. And the antibiotic have a target, and this target means some enzyme or some structure of the bacterium is destroyed or inhibited by the antibiotic. Now, the bacteria come, they are born with an armatory of different resistance mechanisms. Some of them are specifically changing the target structure in the bacterium with a mutation and evolution of those targets. But others are already prefabricated by the bacteria and only switched on when the antibiotic is exposed or exposed to the bacteria. One of those is that the permeability of the cell wall might be changed so that the antibiotics do not enter the cell anymore. Others might be a modification of the antibiotics, for example, the beta-lactamase that M. tuberculosis has, which is one of the most powerful ones among all bacteria. Or the efflux pumps, and there are several of those in the bacterium, and one of the most prominent is the MMP5 efflux pump system, which is also used to pump out the clofazimine and the bedaquiline, leading to bedaquiline resistance. Those are the natural resistance mechanisms which already come with the bacterium when it's born. So the doctors already quite early recognized that a single drug might not be a good solution to treat TB, and they came with the first strategy published in 1950 with anti-TB regimen, which is tackling with the challenge of resistance by combining different antibiotics. And the first curative treatment was published in the early 60s, which was the combination of isoniazid, streptomycin, and paraminosalicylic acid, with a relapse rate of only 4% in the very beginning, after 1 or 2 years after treatment. those combination regimens were later on further improved, but relapse rates increased stepwise and reached 15% in 1967 with the most powerful treatment at that time, because resistance accumulated among bacteria with the use of standardized treatments. So the doctors already discussed different risk factors that can lead to the evolution of resistance in the patient. And one of the most important ones were already recognized. This is changing a single drug in a regimen which is failing, which means when you treat a patient and you're observing a treatment failure or not very good improvement and you decide to change one of those drugs, this is a major mistake because then you risk that this drug is rapidly afterwards also turning resistant. And this is exactly what we observed in the first patient ever recognized with bedaquiline. This was a patient, a Tibetan refugee coming to Switzerland actually, and he was put on MDR-TB treatment because of a pre-XDR TB. And then after 4 months after completing the MDR-TB treatment, the patient developed a relapse. And you see there's quite a prominent cavity which evolved from the smaller one before the relapse. So there is quite clinical deterioration as well. Now please remember the cavity that you see here in the right upper lobe and remember how thick the wall is and just imagine how flexible this cavity still can be for ventilation. This is important because the doctors, for some ununderstandable reason, they decided for a regimen which is quite unusual in the sense that they added clofazimine as the single systematic drug and then amikazine in an inhaled formulation. Now when you add amikazine, you need to make sure that it's reaching those areas where the bacteria are. When you have a cavity which is rather stiff with quite a thick wall, you can imagine there is little ventilation in this cavity happening, so that I can imagine there is almost no amikazine ever reaching those bacteria which are inside the cavity. So it was no surprise that 4 weeks later, after starting this regimen, they had a clofazimine resistance because clofazimine was the only drug reaching the bacteria in this new regimen. They exchanged then the clofazimine by meropenem, again, exchange of a single drug, only meropenem instead of anything else. And a few months later, also meropenem failed because also this became resistant. So then they started another regimen with levofloxacin, Bactrim, and delamanid. Now, levofloxacin was already included in the first failing regimen, which was including moxifloxacin at the time. When you have a fluoroquinolone in a failing regimen, the fluoroquinolone will not work anymore. You can be sure that it's failing also later on. Bactrim is a very, very poorly working drug against TB, so the only acting drug was delamanid at the time. And since the patient did not really improve, they sent the sample to us, and then we recognized that there was already a co-resistance of delamanid and bedaquiline. This was the first case of the combination resistance which was published at that time. The group of Eric Böttger then investigated the genetic changes within this, the population of bacteria in the lung, and they found quite surprising changes. First of all, there was clofazimine, there was a caprimycin resistance evolving by a mutation in the TLUA gene. And then later on, there were mutations which are involved in the folate acid biochemistry in the bacterium, and those are responsible for delamanid resistance. You see those blue lines at the very end of the treatment. This was the time when we received the specimens and recognized the delamanid resistance. So they found mutations which are responsible for delamanid resistance, but only in a portion of the bacteria. Half of them had the mutation, the other half didn't show the mutation, which means it was a kind of a heteroresistant status. And this is exactly what you observe when new resistances evolve in a patient. You start with few bacteria and those become more prominent, and after a while you have a mix of 50-50 or even more. All those mixes are considered heteroresistance because it's not a homogeneous population of bacteria anymore. Well, the mechanism of heteroresistance has been investigated quite extensively also by our group. We found at the time that heteroresistance can be determined also by line probe assays, and with LASIS we observed quite many in the National Reference Laboratory, quite substantial numbers of those cases. The disadvantage of the line probe assays are that they only detect heteroresistance when you have a mix of at least 10% resistant cases among susceptible or bacteria. This means more sensitive tools would be really helpful to investigate the evolution of resistance in the patient in a more meaningful manner. And this new tool is next-generation sequencing. You can use next-generation sequencing to investigate the complete population of bacteria in the samples of the patient. This is called in-depth sequencing because you're really investigating in-depth the complete population, and you can determine the percentage of those with the mutation and compare it with the wild-type bacteria. This has been done in a publication investigating the prevalence of heteroresistance using next-generation sequencing, and the authors found 14 to 38% of such cases, but unfortunately Central Asia was not among those countries. Just a more recent study of Lynn Rigoods, she reconfirmed that in-depth sequencing or targeted deep sequencing has a power to find heteroresistance in less than 1% of resistant population, which means when you have 1,000 bacteria, and you have 10 out of those with a mutation which might lead to resistance, you can determine it with the targeted deep sequencing. This is the tool which we used in Kyrgyzstan in a study which was funded by USAID, the so-called USAID Stop TTH program, with technical assistance from the National Reference Laboratory under the leadership of Dr. Kadyrov, the head of the National TB program, and with extensive help from APT Associates, FHI 360, and other partners. What we did, we involved 2 hospitals and wanted to know how many of the cases are transmitting TB from one another, but we could use the same data set to investigate also the evolution of resistance. Because for all those 707 patients, we restored all isolates which were positive in culture. And this was allowing us to later on sequence those bacteria and to look for mutations which are also resistance associated. We had 131 patients who had subsequent cultures positive. So they had an initial positive culture and then later on at least one more positive culture which was at least 4 weeks apart. We did not recognize any of those cultures which were positive after 1 or 2 weeks after initiation of treatment. But when they were 4 weeks or longer positive after treatment, then we included those. We had several cases with such evolution of resistance. This was one of the cases evolving bedaquiline resistance shortly after the initiation of bedaquiline treatment. Altogether, we observed 12 such cases, and when you calculate now 12 out of 707, it means that 1.7 of all patients showed evolution of new resistant clones within the body during treatment. More importantly, it might be that whenever you have a patient who shows subsequent cultures which remain positive at least 4 weeks after initiation of treatment, then you have almost 10% of those with emerging resistant bacteria. And I think this is quite a substantial number because this is the pipeline where all these MDR, XDR, and even bedaquiline resistant patients come from. And you might have observed also quite a substantial number of beta-quilin resistance in Uzbekistan. We see it in Tajikistan. We see it all over the place here. And I think it's quite worrisome. So we need to be carefully watching those cases. And I think with in-depth sequencing, we have a tool to do it. Those genes which are most frequently affected are the gyrase A and the RPOB gene. The gyrase is the target of the fluoroquinolones. When they mutate, it means that you already have a pre-XDR scenario. All those cases came as MDR-TB patients to one of those two hospitals and evolved MDR, pre-XDR disease under the treatment in the hospital. Now, when all these evolution is taking place, do we have any chance in future to get the TB under control? My feeling is that yes, there will be an answer. First of all, we need to monitor the treatment much better. We need to have a well-informed clinician in the beginning. So we need to be faster in the lab, inform the doctor in the beginning about the complete resistome of the patient. When the doctor decides which regimen would be eligible for the patient. For this, we need to be faster, and with the next-generation sequencing, we have now the tools in hand to be fast enough. Theoretically, we can give the diagnosis of TB and the complete resistance pattern in the hands of the clinical doctor so that he can decide which regimen should work and which one should be avoided within 1 week. So when we really bring this on the road and we use it regularly, and the National Reference Laboratory, but also the peripheral laboratories are well equipped and have all the tools in hand, and also the staff and the knowledge to do it, I think then you are in a position that further evolution can really be avoided. With this, I would like to sum up that every new anti-TB treatment was shortly afterwards followed by new resistances. The first response was that we had combination treatments as we are using it right now, but still with the resistances, with the combination treatments, you still have resistances evolving, particularly when you are changing only single drugs in a failing regimen. This should be always avoided. Even when you change more than a single drug, you need to be sure that the combination of those drugs are fully active and you have at least 2 or 3 active drugs that you bring in. Heteroresistance is the first step that evolves when new resistance are evolving. This is the interim phase. It has been reported in 14 to 38% of cases. I could imagine this is also the range that we have here. At least in Kyrgyzstan, the data said approximately 10% of those with follow-up cultures show heteroresistance and microevolution towards new resistances. And fluoroquinolones are those resistances which are most frequently affected, which is quite worrisome because those are the most important anti-TB drugs for DRTB. With this, I would like to thank all our collaboration partners, particularly in Kyrgyzstan, Dr. Kadyrov, Gulmira, and her team in the laboratory, APT Associates for excellent collaboration during this study, also FHI 360 who helped us with the study, USAID who funded all this, and SEVIM who supported it very strongly during the complete study phase, Katerina Kranzer who helped with the analysis of the data. And I would like to thank you for your attention and your interest.
Thank you very much, Dr. Harold. И я надеюсь...
I hope if you have questions, you will be able to ask them after the plenary session. So, Harold, please join us. Today, at this plenary session, the co-moderator was supposed to be Atajan Ergeshev, director of the Central Research Institute for TB Russian Federation. But yesterday we learned that their top officials are supposed to remain in the country because they have a lot of tasks to do. And the most interesting part is that we knew that, and we were supposed to celebrate Atajan Ergeshevich's birthday. But he was kind enough to send the video of his presentation, and Boris, am I right? Oh, I apologize, Vladimir, because it says Boris. Well, Vladimir Yeremeyev, we will give our colleague an opportunity from Central Research Institute of TB to take the floor, and after that, we will give our gifts, if you do not mind. Dear colleagues, Nargiza Nusratovna, thank you very much for this opportunity to participate in this conference and for an opportunity to convey the warmest regards. Well, I will not read the whole address by Atajan Ergeshevich. He really wanted to come, but actually he couldn't due to the situation. And just some of the key points. The Central Institute of TB congratulates the National TB Center on 3 occasions. The 100th anniversary of establishment of the TB service, the anniversary of Professor Alimov, and 90 years anniversary of the establishment of the Research Center of TB and Pulmonology. And actually, TB doctors and pulmonologists achieved a lot. You developed excellent traditions. You have good capacity, and the accumulated experience serves as a great foundation for further achievements. I'm sure that your energy and your ability to work for the prospects will bring you happiness and satisfaction. So I wish you every success in implementation of all your plans and interesting projects. Thank you very much. Stay healthy and wealthy. So, Atajan Ergeshev, the director of the Central Research Institute of TB. Thank you so very much. I would like to ask you, microphone please, to I need to say that our regards and presents go to Professor Ergeshev and also to Olga Demikhova, professor, who is also staff of the Central Research Institute of TB. And you've correctly mentioned that we have long signed our memorandum and we are working together, implementing various research projects, and I do hope that later on we also will continue our joint efforts, and please convey my best regards. And I'd like to ask our technical team to show the presentation by Atajan Ergeshevich.
Hello. Dear Nargiza Nusratovna, dear colleagues, dear friends, on behalf of your friendly team of Central Research Institute of Tuberculosis, cordially welcome every participant of this anniversary conference. I wish all of you and your families and friends strong health and new professional successes and implementation of all the plans that you have in mind. Today I would like to share the results of scientific research in physiatrics conducted in our institute during the COVID-19 pandemic. It is joyful to hear that the 2021 that was announced as the year of science and research has become the new year in this decade. This is the evidence that the leadership of our country, the president of country, prioritizes the development of research in science, because science determines our future development. In our country, there is a national strategy for TB control until 2025. This strategy envisages intensification of scientific research in the area of prevention, early detection and diagnostics and treatment of tuberculosis. Research is aimed at development of new anti-TB vaccines, new anti-TB drugs, development and pilot testing, and implementing new diagnostic systems for TB detection. All these scientific areas are main activities at our Central Research Institute on TB. During COVID-19 pandemic, the intensiveness of scientific research remained the same. There wasn't even one idle day. We were busy with experimental and clinical studies, and on top of that, new research areas were added to study COVID-19. And I will share this information with you in my presentation. The main areas in microbiology are aimed at improving microbiological diagnostics of tuberculosis and development of new test kits, the testing of new anti-TB drugs, and fundamental research. Fundamental research is always our priority. Typing mycobacteria tuberculosis, genotyping, is a highly relevant problem. Molecular genotyping method of this bacterium has been implemented in our institute in 1995. That's when we organized the first laboratory in our country for molecular genetic testing methods. We characterized genotypic structure of the population of Mycobacterium tuberculosis that circulates in the Russian Federation. We have identified the strains of Mycobacterium tuberculosis isolated from TB patients with HIV infection. They are more clusterized, and there were reliably more mycobacteria with multiple drug resistance occurred in them more often. And we identified also the strains that are resistant to linezolid, bedaquiline, and dolanimide. Fundamental research of another area is understanding the mechanism of development of resistance in Mycobacterium tuberculosis. As you know, once the new TB drugs appear, about a year or two later, the pathogens develop resistance to them. Now, there's a resistance to isoniazid, rifampicin, fluoroquinolones. The resistance to them is available now, but now the pathogen is developing resistance to linezolid and bedaquiline. Understanding genotypic specifics of resistance to linezolid will allow us to develop test kits for quicker development of resistance to linezolid. In our country, in the recent 20 years, we've been observing an increase of mycobacteria caused by non-tuberculous mycobacteria. They're detected only at microbiological labs of TB profile. So we have to deal with non-tuberculosis mycobacteria. We have done molecular genetic epidemiological studies of prevalence of non-tuberculosis mycobacteria, and almost half of the cases in our region were isolated by the pathogen was Mycobacterium aerium. We fully sequenced the 6 types of non-tuberculosis bacteria. The findings will allow us to create new rapid test system for detection of non-tuberculosis Mycobacterium tuberculosis. For us, the priority is to develop new technologies for rapid diagnostics of tuberculosis and mycobacteriosis. In the recent 20 years, several test systems were developed by us. One of the recent test systems was developed together with Central Company to detect Mycobacterium tuberculosis complex and Mycobacterium in one test tube, and also species identification of 12 key clinically significant types of non-tuberculosis Mycobacterium. In addition to that, our laboratory, as part of the international consortium ISTB, is working to develop a rapid test to detect Mycobacterium tuberculosis and non-tuberculosis Mycobacterium and decide on antibiotic therapy, but this work was suspended due to the recent developments in the world, but we will finish it eventually. As you know, in February and March, the new cases of COVID-19 were detected in our country. And in the month of May, our laboratory, together with Central Company, developed test kits for detecting RNA of the SARS-CoV-2 virus. Just like other labs, initially we only used smears from nasopharynx area, and then we used sputum to ensure good quality of samples for the testing. So that it is better for identification of RNA of SARS-CoV-2 virus. It's 2 times higher, the detection rate. And so we achieved negativity status of the SARS-CoV-2 virus in 1 month, and we can see it in 1 month in the sputum sample. While in so we can identify which of the patients may remain potentially hazardous for the people around. So we identified tuberculosis, Mycobacterium tuberculosis complex, and non-tuberculosis Mycobacterium and SARS-CoV-2 in one test tube. And we added changes into the algorithm of diagnostics of tuberculosis related to the need to control the spread of coronavirus infection. Since there was the twofold increase in the number of samples to be processed, we developed a program that helps us to handle up to 96 samples for diagnostics, for both to detect the coronavirus and tuberculosis. So beginning in June 2020, we conducted about 30,000 tests to detect SARS-CoV-2. In addition to that, we identified types of the strains of the coronaviruses. We initially the Wuhan type, and beginning in January 2022, mainly the Omicron strains were detected. We also researched the influence of COVID-19 on the massivity of bacterial excretion in patients with pulmonary TB. Patients who excreted Mycobacterium after the episode of COVID-19, the massiveness of bacterium excretion did not increase. Patients who didn't excrete Mycobacterium tuberculosis after COVID-19 remained the same, in the same status. So COVID-19 does not have a negative impact on the course of the tuberculosis process. The key areas in the area of immunology are shown on this slide. Here, the main focus was on fundamental research in the area of immunology, immunogenetics of tuberculosis on laboratory animals. We combined classical molecular genetic methods, and that helped us to identify the regulator of severity of infection, gene HBAB. We also found a link with production of cytokines. So in organs of experimental animals, we used flow cytometry and identified inflammation caused by tuberculosis, severity of inflammatory processes, and that also allowed us to develop new anti-TB therapies aimed at the host. In the recent 5 years, at our institute, we've been actively exploring microRNA serum of taken from patients with TB to identify the activity of or intensiveness of the TB process. So during the COVID-19 pandemic, we researched the expression of microRNAs in blood serum of patients who were diagnosed with TB in COVID-19. It turned out that these patients have the expression of mature microRNAs was significantly reduced. We identified the expression of cytokines and other materials in patients with pulmonary TB and this status after SARS-CoV-2 that they had. It turned out that 3 months after COVID infection, these patients with TB, their biopsy material, the expression of chemokines was much higher than in patients with TB who haven't had COVID-19. So this says that their inflammatory process in their bodies is more expressed. We identified the preservation of T-cell memory in patients with who have had COVID-19. The people who have had COVID-19, immunological T-cell memory remains in 85% of patients. However, in patients with TB who have had COVID-19, the immunological memory remains in 60% of cases. So we are observing a reduction in immunological memory. At Moscow State Institute, named after Lomonosov, we work with, as our partner, we work together in cellular biology. As you can see from this table, we work in 4 areas. The priority area is exploring the role of proteins responsible for multi-drug resistance in somatic cells of a macroorganism to reduce the effectiveness of action of anti-TB drugs. This opens up a new aspects of understanding the formation of mechanisms of resistance to anti-TB drugs and regulation in the development of the TB-induced inflammation. We need to identify specific functions of proteins responsible for MDR, but this is better for understanding pathogenesis of tuberculosis, but also to improve treatment. Also, identification of reference proteins responsible for MDR in cells of lungs. And we identified PGP, gene MDR1, and MRP. During active tuberculosis-induced inflammation, the expression of these proteins in lung cells increases, especially if the patient is on chemotherapy, excluding rifampicin. Macrophages in tuberculosis-induced inflammation play a very important role. They phagocyte on mycobacteria. The macrophages and their activity, the activity of MDR increase in the process of differentiation, which is the grounds for reducing effectiveness of anti-TB drugs. Macrophages, through macrophages, they spew out anti-TB drugs, and this reduces the effectiveness of TB drugs. This slide shows the benefits of confocal scanning microscopy and immunofluorescent marking for identification of Mycobacterium tuberculosis. Using this technology helps us to increase Mycobacterium tuberculosis detection on the sections, histological sections from lungs. Another important area is creating nano carriers, and based on them, nano drugs. We're researching nano safety on these nano carriers. Of course, this is a very promising area of research because this will be targeted delivery of the TB drugs to the areas of inflammation using nano carriers. The quality of nanocarriers is now being considered by us on diamonds. In recent 20 to 30 years, we've been actively pilot testing and developing new TB drugs. Together with the Institute of Elemental and Organic Chemistry, we've been exploring the activity of triazines against Mycobacterium tuberculosis. And we identified 3 triazines which showed high activity in vitro against tuberculosis pathogens. With the Institute of Biochemistry, named after Bach, we identified the activity of triazines towards dormant forms of tuberculosis. And it turns out that TB, anti-TB activity is evident not only in drug-sensitive TB, but also dormant TB. I'd like to point out that anti-TB activity of triazine exceeds of those of isoniazid rifampicin by 800,000 times. Another priority research area is development and testing new anti-TB vaccines. We prepared the new strain from a virulent strain of tuberculosis, H37RV, through reculturing samples. And we, in the previous study, we used Mycobacterium avium, and here we use Mycobacterium tuberculosis H37RV. From the source strain of H37RV, we had the 70 passages. So we called this strain BN by the initials of Boris Vladimirovich, who is present at your conference. Genetically, this strain is different from the initial H37RV. The new strain lost its virulence towards laboratory mice, but they remain the vaccine-specific qualities. The strain protects mice against tuberculosis more effectively than BCG. The strain effectively protects mice in this line who are not protected by BCG. Implementation of these projects will help us to remarkably improve TB control, both in our country and around the world. Thank you for your attention. Well, you know, it seemed to me that I'm already in the future when I hear about these novelties. Frankly speaking, I'm at a loss for words, but Atajan Ergeshevich did find time in his tight schedule and sent this video address, and I'm thankful to our colleagues from Central Research Institute of Tuberculosis who were able to take part in this conference in an offline mode as well. And here I can sit and dream, though, and wish to all of us to enjoy scientific achievements. We're collaborating from the perspective of research. Of course, I'm looking at my Deputy Director for Innovations and Research, Irina Vladimirovna.
That actually, from the daily routine, we need to move away a little bit and pay attention to research, pay more attention, since our colleagues from Russia have extensive capacity, and hopefully soon we will hear information on new drugs and the vaccines. And I wish you further progress and success to all of us. Yeah, I can see on the screen our dear Anna. As I understand from the US, Anna Meltzer, who worked for several years in USAID office. She didn't just help us, but she was active in our TB control interventions, and the results we are having today will also have your contribution in them. Well, so good afternoon, Anna. We are happy to see you. Thank you so much for your warm welcoming words. Can you hear me well? Yes, loud and clear, but unfortunately we cannot see you in our conference room. Well, we can hear you. Well, excellent. Dear Nargiza Nusratovna, conference participants, colleagues, good afternoon. Assalamu alaikum. And yes, it is my great honor and privilege to participate in this great international conference, and I regret that I couldn't come here, but I hope that we will have another opportunity. Nargiza, I think, well, we can see the beginning of your presentation. Nargiza, I hope you can hear me. Yes, and we see the beginning of your presentation, which you sent in advance, I guess, and yeah, they will help us change the slides. Once again, allow me to say that it's my privilege to participate in this conference. As you said before, Uzbekistan is very close to my heart, and on behalf of USAID team, United States Agency for International Development Office in Washington, Global Health Bureau, TB Division, well, we have always valued your contribution of all colleagues from Uzbekistan, and definitely we will continue to invest every effort. So in the future, our cooperation could only strengthen, and the key aim is to improve the well-being and health status of the population of Uzbekistan in provinces and definitely in other countries. Allow me to once again to cordially congratulate all the colleagues from Uzbekistan on such an important milestone, the 100th anniversary of the TB service and 90th anniversary of the Practical Center for TB and Pulmonology. And now I would like to inform you on the main approaches of our team on contact investigation, how the new approaches support the technical areas, namely the objectives of the reach and prevent concept. So here I'd like to show you why so much attention is paid to contact investigation. As you can see, the quote here says that every TB case was once a contact. And the next slides will show you the specifics, why it is so important. And this also supports two main technical areas implemented by all our USAID programs in all countries, and similar approaches exist for Uzbekistan as well. The reach, which means case finding and prevention. And most importantly, why our strategy aims to investigate contacts is because it is not possible to reach the goal of ending TB by 2035 without significantly scaling up these interventions, without implementation of those programs. And I was happy to see all the achievements, all the programs aim to improve prevention, but at the same time, high-quality interventions have yet to be more broadly implemented at the national level, not only in just one country, but in all countries. which is being done by our team members. And in my presentation, I also wanted to share all the knowledge, experience, and tools available so far. They will be implemented, scaled up, and I need to note that it seems to me, while I'm discussing these issues and making this presentation, well, the team in Uzbekistan is preparing to present the demo project, and Uzbekistan actually was one of the first countries to start implementing USAID grant. So this is the grant to be framework agreement. So actually the demonstration project is being successfully implemented on TB contact investigations. So this slide shows what I explained before. So this is the well-known study, publication as of 2013. So mathematical modeling shows the projections. So if the efforts focus exclusively on preventive treatment, or if you focus only on TB cases, on the active TB, or only on latent TB, but most importantly here we have the black line, which shows that only the joint efforts made simultaneously, or so active case finding plus LTBI finding, only if done at the same time, it can result in effective elimination of TB based on the modeling results published in this study. And we are developing this area, contact investigation, and our vision suggests that this is the very area which can successfully enhance our anti-TB operations. And definitely there are a number of justifications, rationale why our team pays so much attention to this very program-based implementation. This is the rationale shown on this slide. So high yield for new TB case identification, especially among household contacts, close contacts, and definitely it's highly effective and efficient approach, because at the same time you can treat and prevent progression to severe forms. And most importantly, reliable monitoring and evaluation system has been established and is in place. So what we can measure, we can quickly implement. So what's measured gets done as planned based on the indicators. And most importantly, for USAID, reporting is essential, and this monitoring and evaluation framework makes it possible to first improve TB programs at country level. And also we have internal requirements. Annual reports should be submitted to the Congress, and naturally this is in line with all other global priorities to reach the UN goals, and we are grateful to WHO leadership for publishing this well-known WHO guidance on TBCI, on contact investigations. And so this is the theoretical framework for our program, which is implemented in all countries where USAID projects are implemented. These are the key provisions, the WHO recommendations. So target groups need to be identified, but they could differ country to country. And the key question is if we always need to screen and test the contacts. So, well, this is not actually about yes or no as an answer. Definitely yes, but the question is how it needs to be done. And at this conference, I could see, and I was amazed with all the innovations, all the achievements reached so far in the area of implementation, how it could be done. And we need to highlight that monitoring and evaluation need to be conducted for ongoing and communication, provision of information. These are our main areas under USAID projects in close cooperation with national programs, of course. So emphasis is placed on enhanced coverage, so we could provide access to quality treatment, and at the same time coverage also should include prevention programs, LTBI treatment, and enhanced infection control. Definitely, without ensuring sustainable systems, you cannot succeed. And those areas shouldn't work in isolation. They need to be integrated. And that's why our technical areas aim to make sure that we work in cooperation so we could come up with the integrated solution. And in partnership with our colleagues from JSI, John Snow, and North Carolina University, Chapel Hill. So this monitoring and evaluation system was developed, which makes it possible to develop and implement those programs. And I'd like to draw your attention that the M&E framework includes several indicators already embedded in that system, indicators on TB contact investigations, so one core indicator and 12 extended indicators, and also we have the programmatic level indicators which make it possible to measure the program implementation. So this is the overall framework which I explained before, so what objectives we have. And this level is reach, and when you identify contacts or active cases, then treatment is provided. But most importantly, here we enhance prevention. And the guidelines also envisage the TBCI cascade, and here you can see the categories. So step-by-step monitoring and screening of contacts, negative for active TB. And you can see the same cascade for contacts, positive for active TB. So step by step, what is going on, what needs attention, what indicators are required for the step-by-step pathway for a patient who was identified as a result of contact screening. This is the overall pathway, and based on that pathway, we have developed those cascade of indicators. And this is the overall chart, which can be flexibly adapted to all countries, since some countries use different approaches to LTBI detection. But again, I am grateful and I'm pleased to know that Uzbekistan has started using quantiferon, and It is a major step forward because there are portable X-ray machines, AI-based, and it makes it possible to expand the detection services and make them closer to the communities. And also I'd like to draw your attention to some other developments by USAID. So this is the TBCI programmatic implementation toolkit, which is available unfortunately in English only, but soon it will become available in major languages, in Russian as well. And here we have major technical areas, so what needs attention by national programs, and of course, without existing SOPs, without clear distribution of roles, responsibilities, human resource capacity, budgeting, supportive management and development of standards and services and care or quality improvement plans. So this is not possible. Effective implementation of programs is not possible without these aspects. On top of that, our team established the USA TBCI advisory group, and I know that our partners and members of your team, Dr. Parpieva, are part of this group. And here we share experience, introduce best practices, and colleagues from all countries participate in that group, and they can see how data are collected, what the best developments are, and it enables us to develop further strategies and guiding principles for program implementation. And if someone is interested at the NTP, if someone wants to participate in that group, well, let me know and we will be happy to add you to this advisory group. And another important resource which was developed by our team jointly with JSI and the project communications hub, so TB data, and so we developed the electronic resource. This is the training software, so no moderator is required, so anyone can access the website, register, and then they can undergo this online training. And what's important is that definitely it is available anytime, so no dedicated time is required. So I mean, no effort is needed. I mean, if you compare it to offline mode of studies, but again, it's a very important resource, quite extensive. Any person can use all presentations, extra resources, and soon the French version is available, and soon it will be translated into Russian. We plan to have it done by late November, but so soon this online resource for health workers will be available in Russian on contact investigation. So this is available on computers and on mobile devices. You can download it and use it offline.
These are the elements of this resource. It has modules, 5 modules: the basics of TB, the basics of contact investigation, a more detailed third module that explains profoundly how to come up with these programs step by step. And the larger fourth module it focuses on how to explain how to work with the how to do outreach work with the communities. And the fifth module that I extensively explained to you, this is in a more accessible format on data and M&E for conduct investigation. This is the interface, and anyone who desires can look up this resource and using this link. This is our coverage and e-learning outreach that we have now. We have 600 learners from different countries registered on the website. I would like to also express gratitude to our colleagues who took part in the development of this resource, those who are from Uzbekistan and Kyrgyzstan. We do see a significant increase in the number of learners beginning in June this year. After the resource is launched in other languages, we will see an increase in the number of learners from Central Asia and Uzbekistan. In addition to that, the USAID team developed additional resources with, together with our partners, and those resources about effective implementation of joint programs on coronavirus, and with integration of programs on contact investigation. This is about joint screening and testing, not only on at household level, but also in healthcare facilities. Also integrated diagnostic process. Also the diagnostics and transportation, and close link with different activities is important, and this resource is also accessible to all. Thus, I wanted to once again emphasize that there are all these tools that are accessible. If someone has questions or further plans on using these resources, please approach me or Mr. Sevim Ahmedov, who's the lead of our team from Global Healthcare Department and TB team, and we'll be happy to answer all the questions and respond to your wishes and intentions. And in conclusion, I would like to thank all our partners, all our staff, and all the doctors and nurses, laboratory doctors, lab technicians, each and everyone who participates in the implementation of programs and combating TB in the region. Huge thanks for the opportunity to participate in this conference. We highly appreciate our joint collaboration, and we're thankful to our colleagues from Uzbekistan. As always, I wish everyone a successful work today, and today and tomorrow during this conference, and I wish everyone the strongest health and well-being. Jan Rahmat. Anna, thank you so much. I know that it's early morning for you, but you look excellent this morning, and we're thankful that you found the opportunity to speak to us despite of the differences in the times. And I hope to see you in person very soon. And the next presentation is by Bakhtiyor Babumuradov. This is about implementation of the USAID project to end tuberculosis in Central Asia. Bakhtiyor is the country director advisor for TB from USAID Etika. And with this team, we're implementing the 5-year grant. Dear Nargiz Nusratovna, dear colleagues, my presentation is about implementing activities under our project, which is called NTB in Central Asia. As Nargiz Nusratovna has just said, we work in Uzbekistan. My presentation is more of an overview type, because during this conference, my team and myself, we will deliver more presentations in detail with detailed description of our activities, and my colleagues will report on these during the conference. A couple of words about our project. It is meant for all the countries in Central Asia. The geographic coverage is all 5 countries in the region. The key activities are conducted in Tajikistan, Uzbekistan, and Kazakhstan. Also, our colleagues from NTBs in Kyrgyzstan and Turkmenistan are involved into exchange and collaboration. And the implementation period is 5 years. We started in September 2019. In 2020, the COVID pandemic started, and our work slowed down, but we're expecting that we'll finish the project on time in September 2024. The total budget is about 32 million, 5 years for all 5 countries, our key partners. The project is about Apt Associates. I am Red, PATH, and RPX. In other countries, we have partners such as AEW Kazakhstan, NPO AFIF Tajikistan, the Red Crescent Society in Kazakhstan. We're actively implementing our project in partnership. The goals and objectives of the project is to reduce the burden of TB and DRTB in Central Asia. 3 major objectives: to increase the number of detected TB and DRTB cases, and improve the effectiveness of TB treatment, and also all types of drug-resistant TB, and improve favorable conditions and financial sustainability of TB control and DRTB control programs. In Uzbekistan, we work to cover the entire country, but the main focus is on 3 provinces: Jizak province, Sirdarya province, and Fergana province. With total population in these 3 provinces of about 6 million. Plus, we also implement other activities where we cover other provinces. I'll talk about that later in the presentation. During my presentation, you will see these charts. This is how I show the main activity, and then smaller activities follow on the right. You will see how many issues we address under one activity. The first activity is partnership with representatives of civil society for active screening, for active TB case finding. We support active management of persons with TB in vulnerable populations and high-risk populations. Under the project, we have 3 high-risk groups: contacts, people living with HIV, and returnees or potential migrants. There's active coordination of this work with local governments and local partners, where we conducted already 18 coordination meetings with partners, and that's only in the first 3 years of the project, to involve our local partners to address TB issues and also awareness raising, so that they provide active social support for TB patients during their treatment. And under this objective, we are also supporting the implementation of management of people with latent TB infection. We participated in the development of the national protocol on management of people with LTBI. And based on that protocol, we developed training materials, and as of today, 326 healthcare specialists were trained on management of people with latent TB infection. The second objective is to support active case finding of TB in vulnerable groups, and I told you about the 3 groups, and there's there are multidisciplinary teams that were created using the model from the previous project of USAID. These teams include specialists of different profiles, infectious disease specialists, TB doctor, nurse, social workers, and outreach workers, and psychiatrists. And also we work closely with those people who are hard to find. We talk to them and then refer them for further clinical assessment. And we have a separate work on how our MDTs work. But it's now the third year of the project, then I could say that MDTs have surveyed about 19,000 people for about the symptoms of TB, and 8,000 were referred for further assessment. And so these about 8,000 were referred for further assessment, but in reality only more than 2,000 of them were correctly assessed using the algorithm. So the detection rate among these is about 8%. MDTs provide psychosocial support to the patients during the treatment period, especially to those who have DRTB. That requires commitment both on the part of the patient and the healthcare worker. So we created mutual support groups for patients. We have conducted psychological counsel for 460 people to improve their motivation and ensure their adherence to treatment. Another important activity is aimed at strengthening the laboratory network of the TB Control Service. We participated in the development of the National Strategic Plan on laboratories. For the fourth year of the project, we're planning support for full genomic sequencing. Also developed or conducted the assessment for further coverage with gene experts and possible purchase of gene expert machines. 46 gene experts were purchased using USAID funds, and a 16.2 module and a 1610 color XDR, which can be used for XDR. And Nargis Nosratov said that on 6 machines, within 2 hours, you can find the resistance status without waiting for 2 months until waiting for results, without waiting for results or using other methods. COVID helped for us to start actively conducting online seminars for lab specialists as well to improve their knowledge in different areas of diagnostics of TB. This is the map that shows how many gene expert machines were installed in the country and how many were purchased during the 3 years of the project. 46 of them were purchased. 32 module machines were installed in districts, which covered 50 other districts in total, and brought molecular genetic tests to 9 million people in our country. So, so this kind of care was brought closer, decentralized. So then the policy of Uzbekistan is now to bring high-tech medical care and diagnostics and treatment to the population throughout the country. As you know, the TB Care Service actively introduced microscopy, but with the introduction of gene experts, the workload of these labs decreased. They're not as effective, and together with the National Reference Laboratory and our provincial level specialists, we conducted an assessment and with a view of optimizing the laboratory network. So we decided that the centers with the labs with gene experts installed, and those labs which do not have a gene experts installed, depending on their workload, will be transferred into sputum collection points and data exchange points. This was the analysis in 3 provinces last year, and this year we have a plan for optimizing laboratories in Namangan district. Namangan province. And once we get the approval, this plan will be implemented. Now, this optimization led to further discussion of optimizing the logistical network so that we can optimize sample transport so that it is effective, cost-effective, and timely. We came up with this outline and mapped laboratories and the distances and identified their workload. And depending on those findings, we developed the routes for sample transport and how much they would cost. Now the Global Fund partners purchased the vehicles and all provinces use these vehicles for optimal sample transport. An important issue for labs is to build the capacity of laboratory workers. We conduct a lot of different trainings online, both online and on the job, including trainings on DST methods, DC for new drugs, also trainings on servicing and doing tests on gene experts, also remote training for non-pilot or for non-pilot sites. All of these trainings were online. Also, we hired a biomedical engineer who validated all biosafety cabinets in 17 labs and prepared a full report where he highlighted shortcomings that we need to address. And in the coming year, we're planning to either repair or the machines or replace filters or take other necessary actions. And also a tour was organized for the best to the best labs in Bukhara and Nukus, which have good management systems. So from our projects labs, we took to these labs so that our colleagues could exchange their experience and learn about the management control. So this is information about how many people were trained. So trainings on DST were conducted using video equipment, where the lab worker who was performing certain manipulation would put on a webcam on his or her head, and our partners from Germany observed the process in real time and prompted certain actions to take at a certain moment when some corrections were needed. So these were the trainings that were organized so far for 3 laboratories in Fergana, Samarkand, and Bukhara provinces. Now I would like to continue and organize more of such trainings for Fergana and Kashkadarya provinces. So once 46 experts were installed, we provided training for all the specialists at these labs, for 2 from each lab. So there was also validation of DNA extraction from gene expert cartridges for further testing on Hein, doing Hein tests. So this validation showed that the used cartridges with positive samples could be used as sources for further testing using Hein test for further sensitivity testing. I already told you about the training visits. Optimization of the logistical network, as I mentioned before. We optimize sample transport. And
And during implementation, we also realized that we had to train the nurses transporting sputum and the drivers so they could correctly transport the collected specimens. That's why we trained some 80 drivers and nurses so they could correctly collect sputum samples, pack them, and transport. And you see the nurses, they fill out all the documents and collect the materials, the specimens. And the second objective is to improve effectiveness of therapies for TB, all types of DRTB, so patient-centered approach to TB treatment and support to introduction of new procedures for patient-centered care. And actually, as part of this very objective, we conducted training for health professionals so we could implement that patient-centered approach. And again, during the COVID pandemic, we had great need for introduction of video-supported treatment in starting 2020-2021. So preparations took place in 2020, and then we initiated that in 2021. So we procured smartphones and tablets for nurses and smartphones with internet access for patients. So we developed instructions, training materials for training on the ground. So we arranged role plays of patient health professional, and we trained 222 health professionals, doctors, nurses, and so, well, it says 243, but some 270 patients from those 3 provinces are receiving treatment, and the analysis has shown that the effectiveness, well, treatment success rate was 91%. All those who were engaged, who completed this video-supported treatment, 91% completed that treatment. And the image here shows the elderly woman who received that treatment, and we held her get connected, and she showed how she had her pills, and the continuous training.
Продолжение предыдущего проекта USAID продолжили.
So we established the branches of the Center for Distant Learning and Monitoring, and the branch is established in Sirdarya province, and the equipment was procured for Tashkent province and Samarkand and Kakand. And I guess till the end of this month, all the equipment will be installed in, or we will be able to connect to the center in Tashkent and to participate in monthly meetings of the whole community, and also to discuss patient management. And we have weekly concilium, national level, provincial level concilium, where online challenging cases are discussed, information is shared, and recommendations are provided for case management. And we also help broadcast the meetings of the Society of TB Doctors, and we also disseminate information on online concilium findings, then on the RTB rates, and on the STB, so the results of the Central Committee meetings, all difficult cases. So we discuss it all online. A lot is being done to enhance the system of drug safety monitoring system, and it's an important point. So we jointly with the TB and Pulmonology Center, national and provincial branches, we set up the thematic working group. So standard operating procedures could be developed for active monitoring of drug safety, and the working group has developed 10 standard operating procedures. They have been approved, and as far as I know, they were distributed throughout the country, and training was provided for all specialists in the country on how to use quantum software for timely forecasting of utilization of TB drugs. 110 specialists have been trained. Also, we printed out various diagnostic algorithms for clinicians so they could timely identify drug reactions. So Sivtsov table, Shihara tests, and RPX, our partner, we helped them, and we asked them to provide tuning forks, so they could help them timely identify relevant disorders. And as for assessment of operations at the PHC level, seminars were conducted jointly with provincial colleagues. We carry out cohort analysis to see the treatment effectiveness. And next objective is to ensure a conducive environment and financial sustainability for TB and the RTB programs. So we work with the target groups, and we also analyzed gender or other barriers, and Jamila Ismailova will present the findings of this assessment. They are very interesting. Well, you can read her presentation, and if you have questions, she's here, then she will answer your questions. So we organize workshops, seminars, so local authorities could help TB patients. So advocacy efforts were helpful. So these patients could be recognized as vulnerable groups. Guests might be unaware, but we have women's notebooks, iron notebooks, and if those patients are included in those notebooks, then various types of support become available for those patients. And we work with Mahala or community committees and other local organizations so they could pay attention to TB issues. We work with members of parliament so they could advocate for a resource mobilization for patients, for a TB service, well, at least some renovation could be carried out using those funds. And then we organize contests for journalists. We trained 44 journalists from provinces, and they are active in all our activities and publications. So you see some 500 publications on TB-related issues were issued in various media outlets, so you can see the images, the newspapers, and others. So I see that my time is limited. Well, our team also developed several educational materials, videos, printed materials, and all these materials, as far as I know, will be provided for you on flash drives, so you can print them, show them. If needed, please approach us at the end of the presentation. I will show my contact information. So we work with our partner, State Health Insurance Fund, the National TB and Pulmonology Center. So the TB service could be prepared for introduction of mandatory health insurance, and so we are developing the DRGs, so the available funds could remain within the TB service. And for that, we have to prove using real numbers, that those patients require specific resources for treatment, and extra detail is required, and we are having a special session on that, and all our doctors participate in that session. So these are our partners. Hopefully we will continue our activities. So this is just brief information on what has been done in the last 3 years. Bakhtiyor, thank you very much for your presentation. Oh, well, I couldn't say time to you, but in fact, over that time, you have done a lot. That's why I understand you had to share all this information. In the last presentation, this plenary session is program supporting access to quality medicines. The presentation will be made by Azamat Katabekov, although this is the presentation by Archil Salakaya, the USAID PQM Plus Program Management Director, but Archil couldn't come to our conference. He apologized, and that's why his team member, who is based here, will make this presentation. Azamat, please. Yes, make it shorter if possible. Thank you. Nargiza, we would like to quickly present the activities of the PQM project. PQM stands for Promoting the Quality of Medicines, how to ensure sustainable access to quality assured TB drugs. So our project mostly aims to enhance the regulatory function of the pharmaceutical sector, and this slide shows the effects of poor regulation in the country. So what effects you might expect if the country doesn't have adequate regulation, and if it is poorly developed, so higher morbidity and mortality, then it can foster antimicrobial resistance, a loss of trust in the health system, it will undermine efforts of public health programs, and poor regulation might result in use of fake drugs, low quality drugs, and it will jeopardize investment in global health, and also it will result in financial or brand value losses to industry. And a couple of words about this project implementation. So actually this project is implemented by United States Pharmacopoeia, and it's been working in development of the standards, and it sets the standards, and actually the standards developed by USP are used globally. And a couple of words about the project. So this is PQM Plus, which means that we continue the PQM project, and it's a cooperative agreement between USAID and USP. So the main objective of this project is to strengthen regulations in low and middle income countries. And if we we can split our operations in 3 parts. First is strengthening the regulatory systems. Second is development and implementation of assurance of recognition procedures for pre-qualified drugs. And the third part is development of the local pharmaceutical industry. So we will discuss each of those points in detail. So if we take our first objective, regulatory system strengthening, so we work with drug quality control laboratories, and now we work with 2 laboratories in Tashkent and in Andijan. So the objective is those labs need to be elevated to obtain that status for WHO pre-qualification, because if the quality management system is in place as appropriate, then the drugs could be further marketed, but if the drugs are of poor quality, you will not be able to market them. And here we have some success in the registration system. So we, jointly with the local regulatory authority, managed to implement the accelerated registration procedure. So this WHO CRP, it was operationalized. Also, we work with GMP Inspectorate, and it's the government center, which is part of the Pharmaceutical Sector Development Agency. And thanks to technical assistance and advocacy by our project, we managed to convince them establish the inspectorate, because actually in Soviet time we had various inspectorates responsible for GMP, and now we are working with this one inspectorate, and our main objective is to make sure that before they join PICS, they will meet the standards. So PICS is like the club of countries that mutually recognize the results of each other, and the country's government also has plans to improve the standards so they could access this organization. Also, we are working to introduce post-marketing surveillance. Well, given this Soviet heritage so far, until this very year, we had that system of mandatory certification of each and every batch of drugs produced, and as required by WHO. As for post-marketing surveillance, each and every regulatory authority needs to switch to that procedure. And again, advocacy by our project and technical assistance resulted in the fact that a resolution of the President number 55 was issued this January on a transition of the manufacturers with, which are certified in line with GMP. So they could transition to this post-marketing surveillance. And this is actually a totally different system. So quality will be under control with regards to procurement and collection of samples from the market. And actually under this project, we also are using second-line TB drugs, which are being manufactured in the country: levofloxacin, moxifloxacin, and clavulanic acid. And this project will end in December, and based on its results, regulatory documents will be developed covering the whole market. Also, we are providing technical assistance, so pharmacovigilance system could be established in the country. Frankly speaking, the system as such, I mean, on the side of the regulatory system was missing, and thanks to advocacy efforts by our project, we established the unit some 2 or 3 months ago, responsible for pharmacovigilance, and we work directly with that unit from then on. And we are providing technical assistance to develop SOPs, information sharing systems, and guidelines. And in the same manner, well, this activity is more related to COVID. And again, thanks to advocacy under the immunization program, the educational system center was established on AEFI's adverse events following immunization. And actually, we can see that 5 of all of these activities are covered by our project. So some of the functions are beyond the regulatory activities. And if we consider in greater detail implementation of procedures for accelerated registration of WHO pre-qualified medicines in a less costly manner, and here we jointly with the local regulatory authority were implementing the WHO's CRP procedure. So this procedure allows a regulatory body or authority, allows them to register drugs with pre-qualification. It's a more facilitated, easier process, and it's also cheaper. So if the price for this registration was reduced by 40%, which is a significant amount in the context of our country, also the number of documents and procedures that have to be followed during registration was reduced to the minimum. You don't have to translate the dossier or send samples of substances. So here, if we speak about the steps of introducing this procedure, well, Uzbekistan used to sign the memorandum with WHO that it will follow this procedure, but the procedure never worked. But we needed to know why. That's why we completed an assessment of the registration procedure, and then we provided technical assistance together with specialists from the registration department. We developed SOPs and guidelines for manufacturers, updated the price list, and then we started working with the National TB Program, Global Fund, and GDF on conveying these news to the manufacturers so that they that applies to their drugs, that this procedure is in place and they can use. Also, the representatives of manufacturers present in the country, the trainings were conducted on how to use this procedure, or how to follow this procedure. We also would like to thank NTP for assistance that they provided. Now we can say that already 6 drugs which are brought to the country and that are purchased through resources of the state budget are under this procedure, and about 11 more drugs are to be submitted for registration, and they're at the stage of collecting documents. And our third objective is to strengthen the pharmaceutical industry. Here we're collaborating with Nobel Pharmaceuticals, the local manufacturers, so to produce levofloxacin, which is a second-line TB drug, so that it reaches the status of a pre-qualified drug. We're collaborating with this manufacturer in 3 areas. The first one is that we are developing the product itself. We are assisting these manufacturers through consultants from our project to ensure compliance with international standards, and we started collecting information for the dossier. We really hope that by spring next year, the dossier for receiving the status of WHO qualification will be submitted to WHO, and we will be able to request audit on their part. Why is this important for the country? Because this will be the first pre-qualified drug in the region, and it will significantly uplift the production in the country because it will meet international standards. Thank you very much for your attention. Thank you so much, Azamat. Now you can say to Archel, and I will say that to you myself, that you performed very well during the presentation. So we have exhausted our agenda for today. Are there any questions to the presenters? You have the chance to do so now. Please go ahead and ask questions if you have any. Tired, huh? No questions. So I see Askar Adelbayev is speaking on the phone with someone. Well, with your permission, let us sum up or wrap up today. I think that those sections that are satellite sections also are now coming to an end. I think that we worked very fruitfully today.
worked so much that Askar, could you come up or sit here if possible? We had 4 plenary sessions, 8 satellite sections, and 1 school. I think that this is a very tight schedule, and because there are so many presentations were submitted for this conference, we had to organize parallel sessions. So I think that those who were interested in specific questions were able to receive their answers to the questions that they were interested in. And on behalf of all of us, the participants, I would like to thank our international partners who organized, first of all, this excellent conference room with interpretation. I am very thankful to our ladies, the interpreters, who know our terms very well and have been working with us for many years. Thank you for high quality interpretation. Thank you so much. I would like to also thank our immediate organizers, USAID, APT, with the whole team who were preparing for so many days, and our team from MSF, who also made so many efforts, including financial resources and technical assistance was provided by them. All our other organizations, Global Fund and TIFA team, who were the direct organizers of today's program and tomorrow's program, and also the team of NTP, who you see meeting. And I hope that the first day was productive, as productive for you as it was for me, and we will continue tomorrow. Oskar, would you like to add to this? Just highlights of the day. Dear Nargiza Nusratovna, thank you very much for this opportunity to speak. I would like to thank, first of all, you for your diligence, for your openness, for being frank, and your attention, active participation in the discussion. And you also asked questions. I think that all the presenters were pleased to see you in person, because all these long months when we were parted by the COVID-19 pandemic and there was restriction of on travel, this did impact our face-to-face meetings. So when we see each other together, we can hold each other's hands, and it's better than communicating in virtual format. I would like to thank Nargiza Nusratovna for this excellent opportunity, to you, to your team, for our offline meeting, and I wish for this conference to successfully continue tomorrow, and have a good evening. I would like to say that the evening is not over yet. We have another pleasant part of our meeting in general. I'd like to say that the participants of our conference had vouchers for our dinner. They have that in their folders, and the location is also specified there, and our team will take you there to the locations where dinner is going to be conducted. And tomorrow morning at 9 a.m. sharp, I hope that many of you will come here 15 to 9 tomorrow, and we will continue our conference. I wish everyone success, and see you again.